death, myocardial infarction, target lesion revascularization versus optimal medical therapy. This is the reverse of Courage study. So the Courage said that optimal medical therapy is better than PCI, but when you use the fractional flow reserve, you will find that PCI actually better because you are using less number of stents. And when you have a patient with a stable angina and multivessel disease, yes, we can do multivessel disease in stable angina. You can do full revascularization if it is possible with PCI, and this is class 2A in PCI. But if full revascularization is not possible with PCI, it's not advisable to do CABG, to do PCI. But PCI is the rule in STEMI. Primary PCI is the treatment of choice in STEMI patients. Complete revascularization in the same setting or during the index hospitalization is preferred over culprit-only revascularization. And CABG has a limited rule in STEMI patients. CABG remains indicated for cardiogenic shock, yes. Failed PCI, yes. High-risk anatomy and surgical repair of, for example, free wall rupture, septal rupture, papillary muscle rupture. And also, PCI is better for older patients. And if you have an older patients with frailty, comorbidities, and short life expectancy, PCI is better than to do CABG for these patients. And also, PCI can be done for patients with heart failure and preserved ejection fraction, not any patient. And this is a class 1 recommendation and level of evidence C. So PCI is superior for acute STEMI patients. Short hospitalization, early work resumption, and less invasive and therefore suitable for some comorbidities like severe pulmonary disease. The problem is the recurrent myocardial infarction or the recurrent revascularization. And this is because you don't do complete revascularization. لو احنا عملنا complete revascularization, we may be like CABG. What's the problem? Now, this is a study by Bangalore. دي كانت في 2015. They did around 34,819 patients with second generation drug eluting stent. They divided patients 9,000 in the two arms, PCI and CABG, and follow up 2.9 years, and they found similar risk of death in both groups. However, high myocardial infarction but a lower risk of stroke in PCI. إنما higher myocardial infarction with PCI was not significant among patients with complete revascularization. So the advice, if you do PCI, do complete revascularization. Don't leave other vessels like this, except if the other vessels are not for stenting. You do the fractional flow reserve. In the future, I think this fractional flow reserve will come down in price. And now the Syntax extended survival study of 10 years, and they found the primary endpoint of death is less by PCI, and it's near to CABG. And actually, they stay the same with CABG in patients if you have a Syntax score of less than 22, better than you have a Syntax score more than 32. And the all-cause mortality, yes, is better by CABG, but the two curves are narrowed. But the left main disease, no, PCI is better than CABG. And Syntax extended survival study, they reported at 10-year, no significant difference existed in all-cause death between PCI using first-generation paclitaxel, eluting stents, and CABG. However, cabbage provided a significant survival benefit in patients with three-vessel disease, but not in patients with left main coronary artery disease. 2 months ago, my patient did a aortic valve replacement and came into me with unstable angina after this aortic valve replacement. You see, we have three-vessel disease in this patient, LAD, LCX, and right coronary. We did all these arteries in the same setting, and the patient was okay. So how to do this? You can refer the patient to do more cabbage, or she's having already aortic valve replacement 2 months back. Then I have another patient with non-ST elevation myocardial infarction who came in with severe pain, and we did for him revascularization. We see how ugly are his vessels, and total occlusion of the RCA, total occlusion of the LCX, and multiple lesions in the LAD. This is not graftable LAD. You can see again, this is the case, and we actually succeeded in helping this patient and did complete revascularization. Now, the conclusion, the optimal treatment of ischemic coronary artery disease is still controversial. The majority of multivessel disease studies is demonstrated no significant difference between PCI and cabbage in the hard endpoints of death, stroke, myocardial infarction, except in the subset of diabetes. And patients with multivessel disease are complex, and treatment should be tailored on individual basis, taking in account the anatomical and clinical factors with the heart team. This is very important. And most of these trials with multivessel disease showed that cabbage better survival, which was not significant after 10 years of syntax trial. Cabbage was associated with significant stroke, yes. The higher rate of myocardial infarction in the PCI group was related to incomplete revascularization. And STEMI patients fare well with PCI versus cabbage in all ages, and those more than the age of 85 years. The FAME2 study, fractional for reserve versus angiography for multivessel disease, further demonstrate the importance of inducible ischemia in defining those likely to benefit from revascularization. يعني مش أي artery تعمل له revascularization. And the hybrid approach, combining the LEMA to LAD and drug-eluting stents to other vessels, only small studies has been done, and we are waiting for the future results. I advise you, heart team consideration is the key of success in your procedures always. And thank you very much.
Thank you, Professor Mustafa. And because short time, we have only still one last presentation by Professor Hisham Ulanin.
Okay, thank you.
Thank you very much.
I especially welcome Professor Hisham Ulanin, the ex-dean, the ex-vice president of Banha University. You are most welcome to this meeting.
Good morning, everybody, Mr. Chairman, my dear colleagues. Actually, this is a much simpler case as compared to what we have seen by the experts that have shown their cases, but actually this simple case turned out to be a tough one, as we are going to see now. مش هتحرك. So this is a 55 years old male patient. He's a smoker and this epidemic over the last 20 years. He had a history of aspirin allergy, had no significant past medical or family history. He had typical crescendo aortic angina over the last few weeks. His examination was unremarkable. That was his ECG, which showed old and anteceptal MI. Actually, when we dig deep in his history, he had what looked like GIT upset 2 or 3 years before that was diagnosed as gastritis and turned out to be a missed infarction. His echo was looked more or less normal. There was no significant wall motion abnormalities, and he had diastolic dysfunction grade 1. This is his angiography. I decided to do angiography and to see what is going on. He had a lesion in his proximal LED at the bifurcation with a diagonal branch. As we see here, there is a long lesion which is tight, and the diagonal ostium looked okay for me, with a paraosteal lesion that looked like 80%. His right coronary was an intermediate dominant vessel. So I consider what is the best strategy in this patient is provision stenting or 2-stent strategy. And as the ostium of the diagonal branch looked okay, he said this is a candidate for a provision stenting. And this is the usual, as we know, you wire both branches. Then a stent is put in the main vessel. A pot is done to improve the carina, and then we rewire the diagonal branch with a wire in the LED, and withdraw the wire in the diagonal and put it in the main vessel. We can then do kissing balloons, and based on the side of the result in the side branch, either we have a satisfactory result, or we can put a stent, either a tap or a culotte or whatever seems feasible in this patient. So this was my decision. 2 wires, and as the lesion in the LED was tight, I decided to do a pre-dilatation. I used a 20 by 2 millimeter balloon. This was the result is after pre-dilatation, a good flow in the LED, and even the diagonal branch, the flow looked much better. So I went on, I put 38 by 3.5 drug-eluting stent in the LED. And the patient at this point had significant chest pain. And when I did control angiography, I found that diagonal branch is gone. So this is the reason why this patient had chest pain. So as we decided, I just have to pull the wire in the LED and try to recross in the diagonal branch and pre-dilate, and the patient should get better. But actually, this was difficult wiring in this patient. I tried 10-15 minutes every time as a wire could not pass to the diagonal branch. The chest pain became more intense. And actually, the patient started to be a little bit bradycardic and hypotensive. So I said probably before there is no place for nitroglycerin is starting to have hypotension, maybe just try to open this vessel, but there was still difficulty. So I did controlled angiography again, and this was, what I found. A huge thrombus filling the LED, blocking the LED. At this point, the patient became very bradycardic, hypotensive, and actually the patient arrested. Then we resuscitated the patient. I give, considering giving intracoronary glycoprotein to B3 inhibitor antagonist and stop at this point, or give it and continue and try to open this, block the diagonal branch. So this is after giving glycoprotein to B3 inhibitors, giving another dose of heparin, and flushing this artery. I restored TME3 flow. The heart rate was okay, blood pressure is okay now, but still I don't have the diagonal branch. Thrombus resolved, I have time, the patient hemodynamically is okay, so I will have to retry to cross this diagonal branch to open it again. And actually, then again, it was a difficult rewiring and took another 10 minutes. And again, the chest pain started. Another angiography actually revealed that the thrombus is back. And at this time, actually, it is extending into the proximal part of the CX and approaching the left main of this patient. Chest pain more intense, and the situation is difficult again. So what next? Another bolus of glycoprotein inhibitors and stop, or a bolus and continue. So actually, I gave another bolus, thrombus reserved partially, and at this point, I had to think what is going on. Every time that thrombus is coming back, is it the problem of the wires? Is it the stent? Or is it the patient himself? And actually, I had to remember this patient had actually aspirin allergy, and this patient was only medicated with single antiplatelet, which is clopidogrel. And probably this patient had as well clopidogrel non-responsiveness, because it's very strange to have such burden of thrombosis even after giving 2 boluses of glycoprotein inhibitors. So most probably this patient had clopidogrel non-responsiveness as well. So actually, to revise what I did, there is a way to desensitize patients with aspirin allergy. This is the algorithm for this. Actually, we can give montelukast, which is singular known in those patients with aspirin allergy. Usually they come with rhinitis and symptoms of bronchial asthma. And also we can consider giving, if he has bronchospasm, we can consider giving inhalation with corticosteroids inhalation and long-acting beta agonist. And then we start with half dose of aspirin and wait for 90 minutes. This is in elective cases, of course. And then another half aspirin and wait for another 90 minutes. If this patient is not if symptomatic, then I can give a third half, and then the patient can be on regular aspirin from the next day. And sometimes we consider giving either an oral dose of intravenous dose of corticosteroids. However, this is not the only problem, because if this patient had clopidogrel non-responsiveness, it was found that there is a cross-link between clopidogrel non-responsiveness and aspirin non-responsiveness. So probably even if I gave aspirin to this patient and he had clopidogrel non-responsive, I will still have an issue with this patient. So at this point, I thought, should I continue or be wise and stop at this point? So actually, I thought that trying to recross this diagonal branch and keeping the wires in is inviting more thrombosis. So I just withdraw the wires. I kept the patient on table for 15 minutes on intravenous continuous infusion of tirofiban. After 15 minutes, the patient was completely hemodynamically stable, no chest pain at all. I considered loading him with ticagrelor. I gave him 180 milligrams of ticagrelor since clopidogrel non-responsive was probably an issue in this patient. After this, I transferred the patient to the CCU with the disease in place in case I would have to revisit him. I kept him on tirofiban for 48 hours plus enoxaparin 80 milligrams subcutaneously every 12 hours. So after 48 hours, the patient was hemodynamically stable, had no chest pain. Actually, at the beginning when I was transferring him, had some ST segment elevation in lead 1 and AVL, probably because of the diagonal. After going to the intensive care like 30 minutes, this ST segment went back to the baseline. The patient was completely of chest pain. And on follow-up, there was no elevations in the cardiac biomarkers. So after 48 hours, what should I do now? Should I have a second look or just try to re-inject him and see what is going on? And actually, sometimes stopping gives life to others. So I took the wise decision. In my opinion, I removed the sheath. The patient was okay. I discharged him on ticagrelor. I didn't consider aspirin again in this patient. And the patient was followed up actually over 1 year after this event, and he was doing quite well. He had no chest pain. He was doing or leading very active life. His echo afterwards had normal ejection fraction, and there was no wall motion abnormalities in his echo. So the take-home message or lessons in this patient: be planned, be planned, be planned. Actually, what looks simple sometimes turns to be a nightmare. A protocol to introduce low-dose aspirin for non-steroidal anti-inflammatory drugs allergic person is now available. However, clopidogrel non-responsiveness might carry a risk of cross-linked aspirin in non-responders. Ticagrelor is a more potent antiplatelet and may be safer if we have to give single antiplatelet in a patient allergic to aspirin. And finally, the wise interventionalist knows when to push and also when to stop. And thank you very much.
This is a nightmare.
Yes, it is.
It's
Actually,
a very
I
tough
gave him.
situation. بس الآية بتقول من يؤتى الحكمة فقد أوتي خيرا.
Sugar. Actually, I gave him one ampoule of adrenaline, and I pushed in myself like 5 as much endogenously.
This was great. Congratulations for this.
Thank you
case.
very much. Thank you.
Any questions? So thank you very much.
Thank you very
Hisham,
much.
and
Thank
this
you.
session is concluded because of the sake of time. Okay. Thank you.
خدي الماوس والكيبورد دول. اقفلي بس الماوس. لا سيبي ده سيبي ده سيبي الماوس. فين الكيبورد؟ ماشي خلاص.
بسم الله الرحمن الرحيم. We have 4 lectures and دكتور خالد درعم هنا. دكتور خالد. دكتور سامح يبدأ. دكتور سامح سعادتك جاهز. Yeah. طيب we can start with Professor Sameh Shaheen. How to perform optimal kissing inflation both in bifurcation intervention.
من تحت فورورد وصلوا كده.
بوينتر فين؟ والبوينتر ده؟
الليزر مع الاقتصادي ده بس ده ما بيقلبش.
طيب بسم الله الرحمن الرحيم. Mr. Chairman, dear colleagues, actually this presentation is about the latest recommendation regarding the technique of kissing balloon or pot, which is proximal optimal technique or optimization technique. So this is the usual bifurcation, as you can see. This is the main vessel, this is the distal main vessel, and this is the side branch. And so the first question is whether to put the stent according to the size of the mother branch or according to the distal main vessel branch. And obviously, it should be according to the distal main vessel, not the proximal one. But usually, if you do this, you will have malapposition in the larger main vessel, as you can see. And also, you will have obstruction of the ostium of the side branch by the stent struts, as you can see. So let's see how can we overcome such problems. Right. This is again, that's what we can see in optimal optical coherence tomography (OCT). And as you can see that there is malapposition of the main vessel because it's of course larger than the stent deployed, and again the side branch is compromised by the stent struts, as you can see here. And one of the solutions to do this is to do kissing balloon inflation, one balloon in the side branch and one balloon in the distal main vessel. It improves a little bit the malapposition, as you can see, but it turns the proximal mother vessel into some sort of elliptical vessel, not completely circular. This is one of the problems. And it improves also the ostium of the side branch. So it has advantages, the kissing balloon inflation, but still you have malapposition in the main vessel, as you can see here by the OCT, and this elliptical non-circular form of the mother vessel. So the kissing balloon has limitations. And that's why in clinical studies, you can see that with kissing balloon, you will have more target vessel revascularization and stent thrombosis and MACE, as you can see with the comparison of kissing balloon versus no kissing balloon in many clinical trials. So clinically, many limitations with the kissing balloon in the bifurcation technique. And that's why many years ago, even in 2011, Carlo De Mario and his colleagues in Royal Brompton in London, they started, maybe this is the first report about what now we are calling POT. And they stated the importance of doing a POT to improve the bifurcation anatomy in this regard. Why POT? This is the bifurcation again, and this is the plaque. If you choose the stent according to the main vessel, the size according to the main vessel, you are compromising the side branch with disruption of the carina, as you can see here. And maybe also you can induce dissection in the distal vessel, which is definitely smaller after the bifurcation. So, as I told you, the proper is to use a stent smaller than the main vessel, should be according to the distal main vessel. And then you do a pot which will correct this undersizing of the proximal part of the stent. And the pot will stop short of the bifurcation, short of the carina, so it will not disrupt the side branch. This is the proper technique of the pot, as you can see here. Now the vessel is completely covered by the stent evenly, and the mother vessel is properly sized with the stent with this balloon that is chosen according to the size now of the mother vessel. If this stent, for example, is 3, then you will choose 3.5 or even 4 to do a pot for the proximal part of the stent. Again, this is how it looks in an experimental model. As you can see here, this is before pot. A stent is chosen according to the size of the distal vessel after the bifurcation. So you can see here the malposition of the mother vessel, but after pot, the malposition disappeared, improved, and even the side branch. So you have two advantages of the pot. Disappearance of the malposition and improvement of the side branch, as you can see here, compared to after the pot. This is another view of the same experimental model, and another view, you can see the improvement of the side branch, better opening and better displacement of the struts just by doing a proper pot after deploying the stent. And this is again a bench test, a model, experimental model, to see which technique is best for the bifurcation. This is the traditional way to do it, the kissing balloon inflation with symmetrical balloon inflation pressure in both the bifurcation branches. And this is other several techniques using the kissing balloon inflation, sometimes with different pressures. And this is using side branch inflation alone, without kissing. This is a fifth technique. And the sixth and most important technique is using a side branch inflation and then a repot or a final pot. So pot, side branch, repot. This was the first time to test this new technique, doing 2 pots, or pot twice, or repot. And as you can see, the result of this test, a better proximal stent, 3.2 before the second pot, 4.2 after the second pot. The difference and the malposition disappeared from 0.7 to 0, and the stent strut obstruction to the side branch was reduced from 34 to 26. So this was a test that proved to be positive. And this is to prove it by IVUS, as you can see here. This is before the pot with IVUS, and you can see that the side branch might be compromised by the struts of the stent, and this is after pot, better ostium of the side branch. And this is very important physiological test of the side branch. This is the FFR improving after repot. So this is a proof that the side branch got better flow, so that the FFR get better after a second pot or a repot. So what about clinically on patients? This is a comparison between pot versus non-pot, 252 patients versus 939 patients. As you can see here, that the MACE was much less after pot, 4.8 versus 11.7. And in a propensity matched example, again, the POT was 3.8 versus 11.8. So much improvement in patients clinically, not a test on the bench, clinical improvement after POT. So this was a solid indication for the POT in this regard. And the surprising result from this study was that neglecting or not doing kissing is better. Don't do kissing. This was the result of this study, that a POT versus a non-POT, POT was better. But if you are doing no kissing balloon, the result is much, much greater and better than in patients without kissing. Of course, this is not the recommendations in the guidelines, but this was the result of this study. So now if you are doing a provisional stenting for your bifurcation patient, you have three options. First, after deploying the stent, to do just one POT, and then it's done. You have a good result and the side branch is free, so you don't do anything else after the first POT, number one. Option number two is to do a kissing balloon after your POT and then a second POT. So you have to do a kissing for the side branch without putting a stent in the side branch, and then do a second POT. Always end by a second POT. The third option, and this was new, is to do a POT and then just a single balloon in the side branch, and then you end again by POT. So POT, side, POT. This is the third option, and don't do kissing according to this recommendation. Of course, in other two stents technique, you should end by kissing. Kissing is very important in two stent models, but you don't have to do kissing in provisional stenting. This is very important to remember. Even the new techniques of the stent bifurcation, and I will show one of these techniques, which is the jailed balloon technique, always do end by a POT. Always end by POT, even in the newest models. This is how to do the balloon stent kissing inflation. You put a stent here, and underneath the stent you keep a balloon in the side branch in order to be sure, not only a wire, in order to be sure that the side branch is patent. And you do the inflation after removing the balloon, and you do a second POT. So POT is very important even in this new techniques. So this is the final recommendations. POT, sometimes you do kissing balloon, sometimes you do POT, side POT, not kissing, but never do a POT that extends beyond the bifurcation. Remember this. You have to put the dot of the distal dot of the balloon at the bifurcation, exactly at the bifurcation, in order not to disrupt the carina and compromise the side branch. So this is in red. You don't have to put the balloon beyond the bifurcation. And routine kissing is only recommended in two stents technique, not in provisional stenting. The last slide I would like to remind you with is that you have to choose the proper stent for doing a POT, because not all stents can be dilated with larger balloon. If you are putting, for example, a stent in the left main, a 3.5 stent, then you have to be sure that you might need a 4 balloon, a 4 by 0 balloon, or a 5 by 0 balloon in order to do a POT. So you have to be sure that your stent can be dilated. And of course, sometimes you have also to extend the stent a little bit in order to do a POT. Sometimes the bifurcation is very short. It's very difficult to do a POT, but in most of the times you can extend your stent a little bit in order to be sure that a small POT balloon will not disrupt the carina. Thank you very much for your attention.
Dr. Samh, when you will choose a kissing balloon and when you will choose a single balloon in the side branch?
If you are doing a provisional stent and you put a stent in the bifurcation, and if the side branch is compromised, you have the first choice to do a balloon in the side branch only. But then you have to do a second pot. So no kissing in this provisional stenting. But if you are doing a T-stent, for example, or a Kilot technique, then you are putting two stents, one in the main and one in the side, but you should end with kissing balloon. So kissing balloon is important in two stents, but in provisional stents you can do pot, side, pot. It's an option. It's an option. It's an option. But in most of the, like I show you in one of the studies, that kissing may be sometimes harmful in provisional stenting. The most important step is pot, and then a balloon in the side branch, and then repot. The kissing is an option if you feel that kissing, but kissing is not a solution. In my mind, in provisional stenting, I don't do kissing anymore. I just do twice, pot twice.
I think for the importance of put, لازم الاوبريتور يبقى arrange his materials الماتيريالز بتاعته قبل ما يعمل bifurcation عشان ما يفاجئش انه بعد ما حط الستنت ما عندوش بالون سايز ولا لينس ينفع يعمل بوت. فديس فيري امبورتنت.
احنا دلوقتي بقينا في الاساطر لازم يبقى عندنا بالونات مقاس 9 ومقاس 12 فيري شورت بالونز ومقاسات كبيره يعني 4 مثلا او 4 ونص او 5 ومقاس 9 او 12 عشان البوت. نون كومبلاينت بالونز عشان البوت. فذيس از فيري امبورتنت. والنقطه الثانيه اللي حضرتك برضو اشرت اليها ان لازم يبقى في مسافه يعني لازم الستنت اللي محطوطه في المين برانش تبقى طويله شويه بحيث ان انا اقدر احط البوت فيها ما احطوش بره الستنت.
Thank you for this very good presentation. So do you recommend if you have just small disease for 1 to 2 millimeter extending in the proximal main vessel to increase the length of the stent to accommodate the shortest balloon that we have, so we can increase up to 10 millimeter in the proximal main vessel in order to have a good pot? Yeah?
100% agree.
So any questions from?
شكرا.
Thank you, Christian. Thank you. The second speaker is الأستاذ الدكتور محمد صلاح. Dr. Khalid Darahan will talk about a physiology guide intervention and co-registration in ultimate approach.
Thank you for the organizing committee for inviting me for this lecture. Our lecture today will be physiology guided intervention and co-registration. This is the ultimate approach. Actually, what is happening in our practice, including my practice, is we look for a lesion, we assess by visual estimation that is tight, we proceed for BCI by also visual estimation depending on the angio, and we judge on this treatment including by angio. However, a lot of studies discover that the post-PCI residual ischemia is common, ranging from 17 to 33% in different papers, and causes include diffuse disease, geographical miss, inadequate coverage of the lesion from healthy to healthy, and stent under expansion, stent undersizing, and serial stenosis. That's why the DEFINE BCI study was conducted to understand the rate and the causes of this residual ischemia post-PCI. Actually, the results was astonishing. We have almost 1 out of each 4 patients we are doing for him PCI has a residual ischemia. And this is judged by IFR pullback. Yani they are doing the routine angio guided by the usual operator, and then they will do IFR pullback, and they will discover if the IFR results 0.89 or less, this is residual ischemia. So this covers this ratio around, and this study was conducted on around 500 patients, and this covered 24% have post-PCI IFR equal or less than 0.89. And the important finding is that they found that almost 81.6%, yani out of each 5 patients, there is 4 have a focal disease that is amenable for stenting. So they also examined where is this focal lesion is out of this 81% patients. They found around 32% proximal to the stent and around 40% in the stent itself, and around 30% distal. This is the curve of the IFR pullback. As you see here, the stent area is okay, but before the stent there is a pressure drop. So this judging a proximal stenosis untreated before the stent. And this is after the, as we said before, this is a defined PCI published in ACC 2019. They did this blindly after the angiographer decided that I have a successful intervention. And also, astonishingly, they found around 40% within the stent there is pressure drop. And as we see here in the curve of the IFR pullback, we have here almost 0.05 pressure drop across the stent. And this is after the operator judged this is a successful PCI. And this is again focal lesion distal to the stent, around 30%, this including diffuse disease and also hidden focal disease judged by the operator that is not significant. So there is around 80% chance for improvement. Out of the 24 patients, we have focal lesion that can be treated, so the residual ischemia can be reduced from 24% to 5%. So we know that functional assessment serially as FFR, then IFR is in instantaneous wave free wave ratio, and then the pullback curves, which sometimes called the IFR scout, and then there is recently introduced the co-registration. As we see here, this is IFR. We check the distal, the pressure distal and the aorta, not all the cardiac cycle, but in this orange cycle at the diastole, a small portion of diastole when there is no waves. This corresponds to diastolic coronary perfusion. And they found this value is correlated to the hyperemic FFR. And then we can pull it back and do the FFR curves. What's new is the co-registration. Co-registration, actually, this is a joint display of the IFR pullback together with the angiography. How we do it? We usually, as we are doing FFR, IFR, give 300 nitrates, heparin, guiding caster, wire of the FFR, prestige wire placed distally. We ensuring the guiding and distal vessel in the same view. We take usually RAO cranial for LAD, RAO caudal for the LCX to minimize the vessel overlap. And we start pullback at the distal vessel at a rate of around, as you see here, we are doing pullback during co-registration while fluoro is on. And usually take acquisition 30 seconds of fluoro acquisition together with pulling the wire at the same time. So the machine will detect the IFR curve and automatically it is storing the fluoro, and then it correlates both the position of the tip of the wire together with the fluoroscopy. So we have to have the CR not moving. We don't interrupt the fluoroscopy, يعني 30 seconds, 15 frames per second. And then we will register this. And after this pullback, we, of course, we'll check as routine absence of drifts and ensure the aortic pressure is not dampened. This is as routine in FFR. So after the machine records this fluoroscopy and the IFR pullback, it depicts the points of pressure drop along the course of the vessel. So when you move the cursor, you will find the IFR distally, for example, 0.8. When you move proximal, you will find it going up 0.89. Each one of them represent 0.01. So at the cursor, the yellow one, this one, the pressure drop is around here, the pressure at this point is around this value, 0.9, while in the distal value is here. So each point of this represents 0.01. So we have a map in front of us depicting the vessel, and at the same time, we are seeing at each point of the vessel the value of IFR. We have a significant value, of course, is a 0.89 or less. This is significant. So here we take actually the before we are recording, we are making points where the LED is, and then from starting the vessel, from the pullback till the guiding caster. And then, as you see here, this is the pullback in IFR, and then the vessel will automatically shows the these points, which actually, as you see here, each point represent a value of the IFR. So by this value, we can, if you calculate a specific length of the vessel, you can calculate the IFR dropout, yani from, for example, 0.89 to 0.1. So this is not significant pressure drop. So by this way, we can detect whether, because we have automatic 3D tracking, and these locations are actually plotted on the angiogram in an interactive manner. So what are the uses unique to this registration system, co-registration? We can differentiate focal and diffuse. We can measure the stent length required to alleviate the ischemia, not only to cover the healthy to healthy. And we can also, before PCI, predict what is the value of expected after stenting. So this is the pullback curves. This is focal and this is diffuse. But what is new is that we can actually measure the length required of the stent to relieve the ischemia, and we can predict the value of the IFR after PCI. So this is the new. So this new software, Sync Vision, is sold as a separate workstation, and it can detect this IFR dropout and the required length. As we see here, it's calibrated, and we can see at each stent length, we can do the stent. You see here one example. In this angiogram, we have ostial intermediate lesion of the circ. We did the IFR. We found a significant 0.7. It is markedly ischemic. So the co-registration actually tells that in the left main there is plaque but not significant. The proximal lesion, we have a dropout from 0.72 to 0.78. So there is the ostial lesion alone does not explain the ischemia. So if we extended the length of the stent more, the IFR will become 0.89. That's say we relieve the ischemia if we extend the stent from just at the ostium to include also this lesion proximal next to the ostial lesion. So instead of doing just ostial, we can extend our stent. If we extend the stents more, it will not differ, it's the same, 0.89. So this is after PCI. We didn't stent the left main. We didn't include the very distal lesion. So as you see here, we have three values. The first value up, this can tell you the vessel ischemic or no. The second value, how can we benefit from PCI? And these dots, we can measure the distance required for stenting to relieve the ischemia. So, this should be the pathway. Is when you treat the lesion, you can check the significance of the lesion by physiological assessment, not only by imaging, angiography, and then not only it is a gatekeeper, the IFR or FFR as in the guidelines, but the new co-registration can tell you what is the proper stent length required to relieve ischemia. And also, after doing the procedure, when you repeat the IFR, you are sure that we are relieving ischemia. This is the guidelines 2018, what it tells us, and this is very important actually. You have a class 1 to check IFR and FFR. This is the first time to be including the guidelines in instantaneous wave free ratio, IFR. And the second thing that they say that intermediate grade stenosis. The definition according to the ESCC intermediate grade is from 40 to 90%. That's say if you have lesion more than 90, you don't have to do anything. Just treat. If lesion less than 40, also you don't have to do anything. In intermediate lesion from 40 to 90, actually you should have, according to the guidelines, this is class 1A, to do IFR to detect. Why? Because in the FAME2, as we know, 20% of lesions, we said that it is from 70 to 90% turned to be non-ischemic. And also lesion, we said that it is intermediate from 40 to 70%. These lesions, 35 of these lesions turned to be ischemic, especially in the LAD territory. So this intermediate range from 40 to 90 functional assessment is a class 1 now. What's new, which is not included in these guidelines, is the co-registration. Co-registration can tell you the exact length of the area to be treated to relieve ischemia, and you can predict this before doing BCI. And this not have been tested now. In February 11th, that's 2 weeks from now, 2 weeks ago, Philips actually announced the Define GPS global study, and this power to detect hard endpoint whether this new technology and the proper selection of the stent will affect the prognosis of the patient or no. Recruitment of this study will start in the second half of this year and expected after 2 years to have the results. But until now, the guidelines which are there in 2018, in any lesion from 40 to 90%, according to the guidelines, we should have functional assessment with FFR or IFR to proper treatment the patient. Thank you for your patience with me.
Dr. Khalid Darham, it's a very outstanding presentation, gathering of new information. If you have the option in non-bifurcational, non-left main bifurcation. Left main, we all agree on the importance of IVUS, and in some selected patients to do IFR.
Yes.
But in the non-left main bifurcation, which is still debatable whether to use IVUS or IFR, or of course, beside the other criteria about the angle, the size, all these things, but to optimize the outcome in non-left main bifurcation. So which modality you think it should be very essential to optimize the outcome?
Well, actually, as we said in the guidelines 2018, the IVUS till now has no class 1 indication. All are class 2A. But IFR and FFR now is class 1. That's say because the FAME2 trials with astonishing results. Our practice actually, the intermediate lesions, we said that it is intermediate for medical treatment. Around 1/3 of these lesions become ischemic. And even lesions, we said that is 70-80%, especially in the RCA, and discrete lesions with IFR, it is not ischemic. So, and this have been tested with hard endpoints in the FAME trial. So I think, in planning for any vessel, including bifurcation, unless it is very tight, 90% or more, I think IFR is simple. You don't have to give hyperemic or adenosine. Just pass a wire and get it back. If you have this technology, you can do it both in the side branch and the main branch and decide is this ischemic or no. And this is very important.
The other very important point for us, especially patients with diffuse disease, is to define where is the landing zone.
The landing zone, yes. This is the new system. This is the value of the co-registration. It can tell you from this edge to this edge, the pressure drop will improve how much. So you are sure that before you are doing the stent, you are not just doing cosmetic procedure, you are doing a procedure to improve the outcome and the ischemia, relieving ischemia of the patient.
Thank you very much.
Thank you very much for the presentation. My question is about patients with acute chronic syndrome. Is there a role for FFR or IFR in this?
Yes, this is very important question actually. Thank you, Dr. Sameh, for this question, because all the FAME trial and all IFR, FF trials are conducted in chronic stable patients. And this actually guidelines I depicted, this is including in the chronic stable patients. We know that in the acute MI, for undefined period ranging from 7 to 14 days, the IFR and FFR become falsely negative because the ischemic myocardium will not dilate well. So you can have a tight stenosis and the IFR and FFR is negative. There is some small studies saying that you can use it in the non-culprit vessel, but definitely in the culprit vessel, there is false negative results, so it is not recommended in the acute chronic syndrome to use the FFR. In the culprit vessel, this is definite. In the non-culprit vessel, there is no enough data, but there is small studies, range of 50 to 100 patients, several studies said that it is valuable in non-culprit vessels. So culprit vessel definition, usually STEMI is clear, and non-STEMI sometimes is not clear. So this data and FAME trial data even are valid for the chronic stable patients.
Compare acutes actually.
In acute situation, the culprit you have to treat it.
To do a research whether to,
but the non-culprit need further studies. But actually, in what we are doing, we extrapolate this data from chronic stable patient to this non-culprit vessels.
Thank you very much, Professor Khalid. And now it's my pleasure and honor to introduce my friend and colleague, Professor Muhammad Sadak from Alexandria University. He will address the challenge of rescuing the compromised side branch.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, dear colleagues, it's an honor to be here with you presenting this important topic, strategies for rescuing compromising side branch. Actually, by reverting to this important paper from the percutaneous coronary intervention for obstructive bifurcation lesion, the 14 consensus document from European Bifurcation Club, they stated that there has been considerable historical debate about how to assess relative importance of the side branch, and those side branches with lengths measured by CT more than 73 millimeter were most likely to supply at least 10% of fractional myocardial mass. So it's not the issue of the size of the side branch, it's not the issue that it's compromised or not, it's the issue how the length of this branch and most probably to supply more than 10% of the myocardium. And the length of this side branch together with the degree of the stenosis and the length of the stenosis define an important complex side branch lesion which must be always be protected during the revascularization procedure. Actually, as Dr. Khalid said a few minutes ago, assessment and clinical and physiological relevance of many side branches is very important during doing PCI for bifurcation lesion. And as you can see here, revascularization for clinically insignificant side branches can be translated into clinical benefit and maybe even harmful. So you have to make sure that if you are going to revascularize a side branch, this will be translated into important clinical outcome for your patient. And they extrapolated this diagram of relationship between side branch lumen and the cross-sectional area and the perfused myocardial mass. So if you have this side branch here, as you can see here, so this side branch can be supplying an important area, will be compromised by ischemia if you are going to neglect during treatment of this bifurcation. Identification of coronary artery side branches supplying myocardial mass that may benefit from revascularization. They extrapolated that side branches length more than 73 millimeter is an important single factor to treat this important side branch during bifurcation. And from this diagram, as you can see here, the identification of coronary artery side branch supplying myocardial mass may benefit from revascularization. The percentage of fractional myocardial mass in major coronary artery and its branches, only 1 out of 5, non-left main side branches supply more than 10% of the myocardium. It means if you are going to treat bifurcation lesion, from every 5 patients you are going to treat, only 1 patient will get benefit from opening and keep opening this important side branch. And they extrapolate this important score, the size of the vessel more than 2.5 millimeter, taking 1 score, number of vessel, number of diagonals, as you can see here, 1 diagonal, 2 diagonals, 3 diagonals, the left main dominance or apical area supplying by an obtuse marginal branch, and the highest, no branch below the target branch in proximal to mid LAD. And according to this score, you can expect how important this side branch and how be reflected on the supply of the myocardium during treated non-left main bifurcation lesion. So they define a new coronary bifurcation stenosis. If you have a side branch related fractional myocardial mass, if this supplying less than 10%, this is minor bifurcation, just side branch protection. So you have to make a wire in this side branch, jailed wire, to protect this side branch. And if you have more than 10% of the myocardium, so in this important vessel, you have to treat this branch, and you have to end up this bifurcation with open, patent important side branch. And that's why the European Bifurcation Club recommended that jailing wire technique, which consisted in leaving a wire in the side branch while implementing a stent in the main branch, have this important significance. It's keep the side branch open, good marker for the side branch ostium, modify favorably the angle between main branch and side branch. Not working with 2 wires is an important predictor of side branch occlusion, decrease the risk of target vessel revascularization. And this important jailed wire is modifying and acting like an anchoring wire while introducing your guiding and introducing your material into this bifurcation. So not all true bifurcation are completely the same. So you can see here, this is 2 bifurcation 111, but trying to jail a wire in this diagonal is completely different scenario in these 2 different bifurcation. So what about the difficult bifurcation anatomy? It's wide angle between main branch and side branch more than 90 degree, complex lesion within the bifurcation like long lesion, calcification, aneurysm, tortuosity or lesion proximal to the bifurcation. All of these are predictors to a great challenge trying to wire the side branch, and it's a predictor to loss of this side branch if you're not going to jail it before doing the stent of the main branch. There are general rules to facilitate wiring. Careful review of the angio prior to the attempt, plan A and plan B. Select 1 or 2 optimal projection. The bigger the angle, the better the view. Select good backup support, avoid Judkin casters, try to use APU catheter, Amplatz left, and 3D RC. Actually, you have different curve for trying to wiring of the side branches, the single bend like this one, or single bend with long tip if you have the parent vessel is of great diameter, wide smooth bend, and double bend curve. So according to this bifurcation anatomy, workhorse wire to start with, like BMW and a simple wire, then use torque to control your wire. This is the simple curve. Sometimes it doesn't work with important complex anatomy, so you need to use special techniques. The first technique is the bull back technique. So you have to make your curve like this way, passing the bifurcation into the main distal vessel distally, then trying to retrieve your wire then the wire prolapse in the side branch. Another important tip is the long U-shape technique. So you make a very long U-shape like this way, passing this U-shape distally into the main vessel, then pull back with anti-clockwise rotation, then your wire prolapse into the side branch. This is a second tip. You can use it for complex bifurcation. At any time, you have to change your guiding caster to improve your support, reshape the tip of the wire, consider new wire, change projection, adapt the fluoro quality, and you can ask a colleague about opinion. This is important tips increasing your chance of success. And you have the wire escalation. After using the workhorse wire, and if you have failed, we are usually advise that you use a Felder FC wire, Felder XT wire, and Sion black wire. And sometimes, if you have a very complex anatomy, you can use an added support by what's called venture wire control catheter. This catheter is dedicated to use it to engage the ostium of a complex side branches. So this catheter, you can turn it like side by side and increase the wire and tip control, easy wire exchange before after crossing. So you have to pass this venture catheter over the wire, then retrieve your wire, prolapse it into the side branch, then advance your wire. And this dedicated algorithm from Euro Bifurcation Club, if you have a difficult side branch access before stenting, pull back technique, reshape the wire tip, move to the soft wire, Felder FC, Pilot, and Sion, microcaster, dual lumen like Supercross and Venture, long U-shaped reverse wire. Sometimes you can rotablate the major vessel if you have a severe calcification, sometimes doing plug modification by pre-dilatation by NC balloon, and finally you have a wiring success. All of this effort you have to pay in order to put a wire in this important side branch, because you have a great regret if you are not going to put this wire after loading it in the stent in the side, in the main branch. Because you have a great incidence of side branch loss or occlusion in provisional stenting. In the Vawi hospital, they have 7.3%, and in the other literature, it's ranging from 8.4 up to 19% of side branch occlusion in bifurcation lesion. So when to bail out to do a stenting of this side branch? If you have a residual stenosis more than 50% after doing the main vessel, if you have type P or higher grade dissection, TIMI flow less than 3, from BBK2 criteria, extensive dissection, impaired flow with TIMI less than 3 grade flow, residual stenosis of the side branch more than 75%. All of these criteria, if happened, it's indicated that you have to put a stent in this important side branch if it's supplying more than 10% of the myocardium. And as you can see here, we always use these techniques to cross the stent into the side branch. We are trying to great effort to pass from the distal stent struts. Of course, all of us are, while you are passing the stent, you are doing your job, but you have to spend some time to pass distally. Because if you are going to pass distally from this diagram, you can see here, you are pushing a great part of the stent into the ostium of this side branch, so the incidence of restenosis in this area will be very low, except if you are crossing from here, so not covering, and you change the carina more proximal, and you have a great incidence of restenosis. And if you are finished by this way, you can do the tape technique, which is a very simple technique in the bail-out strategy in 90% of the cases. Sometimes you are going to fail to cross this side branch, so they invented this technique, the jailed balloon protection. It's a new technique to avoid acute side branch occlusion in a best report from the first clinical experience. So you have to put the main vessel stent like this way, and you put 2 millimeter balloon in the side branch, and after deployment of the stent in the main branch, if you are going to lose this side branch, you can deploy this 2 millimeter stent in the side branches, and after that, after deployment, you do pot technique again, recrossing, and you final kissing balloon, and you store the flow. So it's a very simple technique. You can use it if this side branch is an important side branch. And as you can see here, after 4 years of follow-up, jailing balloon versus non-jailing balloon translated into freedom from death and MI and TLR after 4 years with a great significant difference. Another technique is the inverted crush technique for uncrossable side branch occlusion during provisional side branch stenting, a new rule for the jailed wire and jailed balloon. Like this way, after jailing of this small balloon, you can crush the stent in the main vessel and putting another stent. It's called it inverted crush. All of these techniques are the bailout to put a stent in these important side branches. Finally, wiring of the two branches of the bifurcation is crucial. Optional wire device strategies to deal with complex side branches access. When wiring is difficult, recrossing can be worse. Consider treating this branch first, and this is a very important note. And finally, God bless our Egypt with a multiple bifurcation branches. Thank you.
Outstanding as always, Muhammad. And this is a very detailed presentation on a very crucial problem, which is the side branch, how to manage and how to rescue. Sometimes it's very difficult and you spend some time. Do you think that angiographically you can only rely on the residual 50% lesion in the side branch? And what about the Podkey spot and the pod side pods? Maybe you can judge after you try just the simple balloon before you decide for stenting. Because this was in the letter, this was in your presentation in 2016, but I think we are now more conservative than before. So maybe if you can try just the pod side pot or Podkey spot, although it is supplying maybe 10%, although and we are not sure of that. But what do you think of that now
Yes.
in these days?
Actually, after, if you have a jailed wire in a side branch, and this side branch is compromised, you have to ask your question before. If I'm going to do a final kissing or pot side pot, whatever you are going to do, if I left this side branch with STEMI 3 flow like this way, this patient will be translated on important clinical outcome later on or not. As I said before, 1 out of 5 of these important side branches is translated into important clinical outcome. That means you can put a stent in a side branch, which is not necessary, you have to put it. So after doing pot side pot or kissing, you can judge, I leave it like this way, or I can put another added stent. So dissection, TME1 flow, long lesion, all of these are predictors of the putting another stent.
Thank Dr. Mohammed for this kind and nice presentation. Shall functional assessment of the side branch in absence of a dissection can predict this clinical outcome?
Yes, but actually it's important before doing the provisional stenting or two-stent strategy, you have to ask yourself before embarking into the bifurcation. So in my point of opinion, you have to have the strategy before doing the bifurcation first. If I'm going to, this is an important side branch, I'm going to put a stent first because its crossability is difficult. If not, I'm going to provisional stenting. After provisional stenting, if you have an FFR on the table, you can use it simply to assess if you have TME 3 flow or not. Thank you. Thank you.
So it's a great pleasure for me to introduce Professor Dr. Mohammed Lotfi, Professor of Cardiology at Alexandria University. His talk titled High Risk Bifurcation Intervention, Learn from Cases.
Mr. Chairman, dear colleagues, it's my pleasure to present this presentation about high-risk bifurcation intervention, learn from cases. If we're going to talk about high-risk and bifurcation, it will be the left main and acute coronary syndrome. So the combination will be patients with acute coronary syndrome and bifurcation lesion. Our first patient is a male, he's 54 years old, he's diabetic, a heavy smoker with COPD and dyslipidemic. He presented to a non-PCI capable hospital with extensive anterior STEMI, and the patient was shocked in the ER. The patient arrested, CPR for 6 minutes, and he was, they have to put the patient on mechanical ventilation and to give him IV noradrenaline, and the blood pressure of the patient improved to 90/60. They called us in our PCI capable center, and the patient was transferred within 75 minutes. The ECG showed raised AC segment 6 millimeter from V2 to V6. troponin was positive and CKMB was high. Echo screen in the ER showed ejection fraction of 34%, severe apical and anterolateral hypokinesia. There is no question that this patient must be transferred immediately to the cath lab in order to do coronary angio to see the coronary anatomy. Angio showed this ugly lesion. We have a total occlusion at the ostium of the LED, total occlusion of the circ, and as we can see here, this image, every one of us as an intervention cardiologist would not like to see it as a patient with acute coronary syndrome. Spider view, we can see total occlusion of the LED and totally occluded circ. The right coronary artery was not free from disease. There is a lesion in the mid segment and included posterolateral branch. So how should I treat these patients? I think that we have to revascularize. The only option for this patient is to revascularize. It's a life-saving to do revascularization with the minimum time and the minimum complexity of the procedure. So I started with wiring of the LED with a regular BMW wire. Balloon pre-dilatation, wiring was not so easy because of the ulcerated lesions present at the ostium, and after balloon pre-dilatation we find that the vessel is also calcific. It's a calcific LED, it's not easy. So I did the balloon dilatation with a long non-compliant balloon. It's an AccuForce non-compliant balloon, 2.5 by 30, and here we can restore the flow. We have a combination of thrombus plus calcium in the midlad, and I try to advance a 48 millimeter everolimus eluting stent. It's failed to pass because of the calcification. So rapidly I restarted to do further balloon dilatation using another larger non-compliant balloon, and finally I succeeded to pass the first long 48 millimeter everolimus eluting stent in the mid segment. Here I pre-dilated second, and in this view I see that I have to stent from the left main to the LED. I cannot skip from stenting of the left main. So I wired the occluded circ. I was not concerned at that time to open the circ. My main concern was to restore the flow from the left main to the LED. This is very, very important because I have left main, I have an extensive anterior MI, and the patient clinical condition was not so stable. With every balloon dilatation and every manipulation, there is runs of non-sustained VT on the monitor of the cath lab. So I passed the second long everolimus eluting stent from the left main to the LED, and here I pull back the wire because there is a twisting of the wire on the table, the wire on the circ and the wire on the LED. So I know that the ostium of the circ was normal, so I decided to put the stent like this, and then I did non-compliant balloon dilatation, multiple balloon inflation with use of non-compliant balloon, and the final pot was a 4.5 by 50 millimeter in the left main, and I can restore the flow from the left main to the LED. At that point, I decided to rewire the circ. I passed the floppy wire to the circ. I opened the Strasfurt with a small 1.5 millimeter balloon. Then I did a kissing balloon dilatation for the left main and left circumflex in order to restore the flow. And then I tried to open the circ gently. So I passed the wire to the distal circ, balloon dilatation with a small balloon, and here I tried as much as I can to restore the flow without putting a stent, in order not to put long stents in this hemodynamically unstable patient, and I didn't see the patient alert. So my main concern was to do the least possible intervention to restore the flow and to restore the hemodynamics and to stabilize my patients, and then to do further revascularization. And here we can see that we have a TIMI3 flow now to the occluded circumflex only with prolonged inflation of non-compliant balloon, and the LED, as we can see here, we have a TIMI3 flow, and the circ, we have a TIMI3 flow with balloon dilatation. I have a lesion, residual lesion. Yes, I have a significant residual stenosis. There was no dissection. I waited for 10 minutes, and took a last control angio, and I have restoration of the flow to the circ, and I decided to stop at that point and not to put 2 stents in the circ at that time in order to stabilize the patient condition and then to do further revascularization. The patient was kept on mechanical ventilation for 48 hours, weaning from inotropes after 72 hours. He was discharged to room on the 5th day, and he was discharged to home at the 8th day. The action fraction of the patient improved to 45%. He has mild mitral regurg. He is planned for controlled coronary angio for further revascularization, but the patient himself and his family, because of this nightmare for them, they are asked me to postpone a little bit the second session to complete revascularization of the circ and the right coronary artery. This intervention was done in January 2020. My second patient is a patient who is 56 years old. He is diabetic, heavy smoker and dyslipidemic, presenting with unstable angina, COPD, diabetic nephropathy, with bilateral severe lower limb ischemia, with diabetic foot infection. The ECG showed ST depression in V3 to V6, troponin positive, and the echo showed ejection fraction of 50%, anterolateral and wall was hypokinetic. Coronary angio showed a significant ostial left main and left main stem lesion, proximal LED, medial LED, and this is the angio as we can see here. When we touch the left main, there is damping, severe damping of the pressure, severe chest pain, runs of VT. So it was rapid shots for the left system. As we can see here, we have a significant ostial left main and left main stem and proximal LAD. And this is the lateral view. And the right coronary artery was also not free from disease. There is a significant mid-segment stenosis. So the syntax scores of this patient was 33. And the clinical syntax score, the PCI mortality at 4 years is 35%, and CABG mortality at 4 years is 35%. So this patient is both for CABG and PCI, he's a high-risk patient. And the Euro score is 19.3%, so as you have a high Euro score and a high syntax score. I stopped after the angio. We did a heart team consultation. The surgery was refused because of the presence of diabetic foot infection with methicillin-resistant staph, advanced peripheral arterial disease, and pulmonary function test revealed obstructive and restrictive lung disease. So we have to treat or to revascularize these patients with PCI. There is no option for surgery. So we started by wiring of both left main and left circumflex, and here I took a GL 3.5 in order not to damp the pressure. This is, for me, it is not of good support, but for the patient it's better not to have damping of the pressure while I'm wiring. And I took rapidly to stabilize the left main LED. We took a long Everolium stimulating stent from the left main to the LED, then a second stent in the mid segment of the LED. And after stenting and POT, there is a significant compromise of the circ. So it was a little bit difficult to rewire the circ. And finally, with the use of run-through wire, I succeeded to rewire the circ while keeping both wires, the circ and the LED in place. Don't never ever in these patients with complex anatomy to withdraw one of the wire, take a new wire to wire the side branch, and don't play with the main branch wire. First, I opened the struts of the stent with a small 1.5 compliant balloon. And my decision here in this patient to do provisional side branch stenting, so I did balloon pre-dilatation first with a non-compliant balloon. Then, after meticulous manipulations, I could pass the stent from the left main to the circ. The angle here was not so easy, it's 90 degrees. Finally, I can cross the stent, and I preferred to have a balloon inside from the left main to the LED while positioning the stent in order to be sure that I'm covering the ostium. I withdrew a little bit the stent of the circ while inflating at low pressure the left main LED balloon. And finally, after kissing balloon dilatation with 2 non-compliant balloons, I restored the flow to both the LED and circ, and we have a distal lesion in the OM, distal circ and OM, but I preferred not to go further because this patient has also, he's diabetic with diabetic nephropathy, so I preferred not to do this distal lesion. The RCA was done in the same session. We used 75 millimeter of contrast, Judkins to the right, and one long drug-eluting stent, post-stenting balloon dilatation, and good final angiographic result. This is the final result for the RCA, and the final result for the RCA with a TME3 flow to both branches. 1 year follow-up of this patient was excellent. No instant restenosis of both left main and circ, and the RCA, the left main stent, as we can see here, we have minimal neo-intimal proliferation of the osteum, which is accepted around 30% at the osteum. It's accepted after 1 year, and the RCA was perfect. The patient was kept on dual antiplatelet. I think this patient with peripheral arterial disease. He has to continue on dual antiplatelet for life, not to stop dual antiplatelet, aspirin and clopidogrel or aspirin plus ticagrelor low dose. My take-home message that patients with diabetes and complex coronary artery disease, both patients were diabetic with bifurcation lesion and complex anatomy. The decision to proceed for coronary revascularization must carefully consider and incorporate all clinical and angiographic characteristics and the circumstances of each individual patient, and such a decision should only after discussion with a multidisciplinary team. The first patient I don't have a time to discuss with the heart team. The second patient you have to do a good discussion with the heart team. When you do the two-stent strategy, provisional stenting is recommended for the majority of bifurcation and trifurcation. POT, as said by Professor Sameh Shaheen and Professor Sada, is an essential step. Kissing balloon inflation is optional in provisional stenting and obligatory in two-stent strategy. If you implant two stents in left main circ, you have to do kissing balloon dilatation. Thank you.
Those are quite very challenging and complex cases. I hope that not all the bifurcation cases are always complex, but maybe the difficulty in if you don't have if you have these patients in the setting of acute coronary syndrome, then sometimes you may try to make the procedure more simple. So in case of two-stent strategy, what are the criteria on your personal basis which you decide from the beginning that this patient with bifurcation, it will end up with two stents?
The left main, setting of left main or
non-left main?
Non-left main, as said previously said by Professor Sameh Shaheen and Professor Sada, according to the size of the side branch and the length of the side branch, and you can assess how important this side branch is. So if we are talking about a side branch more than 2.5 millimeter with a lesion length more than 5 millimeter and the length of the vessel is more than 73 millimeter, you have to consider this vessel as important, and you try as much as you can to preserve this side branch either with a one stent or two stent strategy.
And in your personal records, what is the percentage of the patients referred to you with a syntax score over 32, like one of these two patients, and still you do for intervention? I mean, is it a trend now for all of us? Very high syntax score.
I think to do we are pushing a little bit the boundaries for PCI. We have in our center our experience as regard the multivessel disease with low syntax, intermediate syntax, and high syntax. According to the guidelines, low syntax is PCI, intermediate syntax in diabetics surgery. Honestly, when we did intermediate syntax up to 27 with a very good result. If you have a 27, less than 27, we have a very good result and very good long-term result up to 4 years. And if you are dealing with a syntax score more than 27 with a complex anatomy or more than 33, I think the priority, if the patient especially is diabetic, refers the patient for CABG. This is the best according to guidelines. And in the previous session, there was a word that الحكمة مهمة، يعني judgment مهم، الحكمة. فربنا يأتينا الحكمة ان احنا ناخد القرار الصائب لمرضانا، مش لازم ان احنا نبقى يعني فتوات في البي سي اي، يعني you should be reasonable.
Thank you, Dr. Mohammed.
Thank you, Dr. Mohammed. Now we close the session. Thanks for all.
think we have to start. This is the Boehringer Ingelheim Symposium, and I have the pleasure to have two eminent speakers in this session, Professor Ihab Atiyah and Professor Ahmed Shawqi. They will give us two talks about the empagliflozin. One of them, which is for Professor Ihab Atiyah, is about the real-world evidence for completing the randomized clinical trials. And as we all know that in the era of the evidence-based medicine, the randomized controlled trials are the base of studying any drug, but the real-world evidence completes these randomized clinical trials because these are the actual life in our hospitals and for our patients. So Professor Ihab Atiyah will give us a talk about empagliflozin, real-world evidence completing randomized clinical trials.
Thank you, Professor Sameh, for your kind introduction. We're going to talk about the new sodium glucose cotransporter 2 inhibitors that are really a breakthrough and very important for us in clinical cardiology as well. As a background to the use of the SGLT2 inhibitors, we have to know that our diabetics, the diabetics that we treat, the ones that we see in our clinics, they have an early cardiovascular disease. They don't die from diabetes, but they die from cardiovascular disease, and they die usually 10 to 15 years earlier than those who are non-diabetics. And despite our advances with the standard care, most, like I said, of diabetic type 2 patients die from cardiovascular disease. That's the main cause. The disease starts earlier. The cardiovascular disease starts even before we diagnose diabetes, even before it is known. Since the stage of pre-diabetes, you have all the risk factors causing cardiovascular disease, although it is silent. And then when diabetes occurs and progresses, it becomes even worse with more macrovascular complications until it leads to death, unfortunately. So to address this issue, they are always looking for new anti-diabetic medications, but they have to prove that that medication has to be safe for cardiovascular outcomes, and it's a prerequisite now by the FDA. You cannot accept any new diabetic drug without proving that it's safe on cardiovascular outcomes. And that's the background for doing the EMPA-REG outcome study. It's an outcome study studying the sodium glucose cotransporter 2 inhibitor empagliflozin, and it's important to see the outcomes on cardiovascular disease. Actually, this was a randomized, double-blind, placebo-controlled cardiovascular outcomes trial, and it included patients with type 2 diabetes with established cardiovascular disease. They already had established cardiovascular disease, and it covered 42 countries involving more than 7,000 patients, and they were randomized 1:1:1, either placebo on top of standard of care. I mean, all these patients took standard of care, and on top of them, it was either placebo or empagliflozin 10 milligrams daily or 25 milligrams daily. And the primary endpoint was the 3-point MACE. The 3-point MACE specifically looked at cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, and there were other important pre-specified outcomes. And it's very important to pre-specify the outcomes because it allows you to have significant statistical analysis at the end of the trial. And they looked for hospitalization for heart failure, all-cause mortality, as well as incident or worsening nephropathy. So this was an important parameters to look at. The key inclusion criteria were adults that are 18 years or older with type 2 diabetes mellitus. Their glycated hemoglobin had to be between 7 and 10% during screening, and they had to have, like I said, established cardiovascular disease, at least either coronary artery disease, peripheral arterial disease, myocardial infarction, or stroke, and their body mass index would be less than 45 kilogram per square meter. Important to look at the exclusion criteria, because these are the patients that you would really be worried to use the agents in. Those with an eGFR less than 30, or they did not include in the study the patients that had a recent, within 2 months, acute coronary syndrome, stroke, or TIA. These were not included in the study. When you look at the key line and the baseline characteristics of these patients in the study, you find that they were all at high cardiovascular risk, and they were well controlled for the modifiable cardiovascular risk factors. Glycated hemoglobin was averaging 8.1%. The body mass index was 30. Established cardiovascular disease, 99%, because like I said, the study insisted they had to include cardiovascular disease. eGFR was 74, and the blood pressure was a mean of 135/76 with an LDL of 84 milligram per deciliter. They were receiving standard of care, best medications that we use in our everyday, antihypertensives for 95%, and it included ACE inhibitors or ARBs in 81% of these patients. 81% had lipid-lowering drugs, 77% were on statins, and aspirin was used in 83%. So they had perfect standard of care treatment, and that was a baseline medication. When we look at again, the baseline, how many patients had coronary artery disease? More than 75%. So we have a study that had more than 75% of patients having already established coronary artery disease. There were other patients having peripheral arterial disease, history of stroke, etc. But mainly, 3/4 of the patients had coronary artery disease, which is an important thing to keep in mind. Looking at the results of the primary outcome, like I said, the pre-point MACE, it's in addition to the standard of care treatment, we got an impressive relative risk reduction of 14% with a p-value of 0.001, and also not only being non-inferior, but it allowed to do a superiority test, which proved to be of a p-value of 0.04, which is significant, means that it is not only non-inferior, it is superior to the other types of treatment. So that was the first primary endpoint of importance. What was really impressive was an impressive relative risk reduction of cardiovascular death, 38%. And if you look at the curves, you find that the curves are diverging very early. The benefit is occurring very early on, even within the very first few months of the study. And this reduction in cardiovascular death was the main driver for the benefit in the primary endpoint. When we look at hospitalization for heart failure, again, we find very impressive figures. We find a 35% relative risk reduction, and the benefit starting from the very first month. You look at the curves, you find they are separating very early in the study, and it's getting more with continued use of the drug. So this was important, with a very significant statistical p-value of 0.0017. Looking at all-cause mortality, because we are interested as clinicians in not only cardiovascular death, but all-cause mortality. All-cause mortality was, again, relative risk reduction of 32%. Very impressive, 32% with a very significant p-value. So to summarize the benefits from the use of empagliflozin in these patients with established cardiovascular disease having type 2 diabetes, we look at, in addition to standard of care, it got an impressive 14% reduction in the 3-point MACE. Like I said, main driver was cardiovascular death with 38% reduction, and all-cause mortality reduction of 32%. Hospitalization for heart failure was reduced by 35%, and the safety was, as I'm going to show, consistent with previous trials. But we have to look again at the all-cause mortality of 32%. How many other drugs that we use in our secondary prevention measures that would give you a 32% reduction in overall mortality on top of standard of care therapy. How many other drugs that we know? This is quite impressive. If we look at older trials, we look at the pre-statin era, looking at patients before the statins were standard of care, and we see you all remember what simvastatin did when you got a number needed to treat of 30 patients to prevent one event. For treatment included 5.4 years. So this was early in the 90s. And in the 2000s, when even statin use was less than 29%, before the standard use of ACE inhibitors or ARB, looking at the ramipril for 5 years, you got 56% number needed to treat again for 5 years in order to prevent one event. Looking now at the empagliflozin, on top of patients that had ACE inhibitors and ARBs, 80% of them are on proper ACE inhibitor and ARBs, 75% on statins. Already these drugs will reduce the events, and on top of this, you got a number needed to treat of 39 for 3 years in order to reduce an event in these high-risk patients. So that is quite impressive because it's on top of standard therapy. Some might ask, I ask myself, what's the mechanism? Possible, why should an anti-diabetic like a sodium glucose cotransporter 2 inhibitor give us all this benefit? Because we're looking. Well, when I looked at the literature, you have all these possible mechanisms. You can just go through them. I'm not going to read them. You can just go through them and see if they are going to make any sense. But all of these were possible mechanisms to explain the improved cardiac function with these sodium glucose cotransporter 2 inhibitors. Anyway, another important thing is that the study proved that this is a very effective and safe drug to be used for diabetics. But in addition, we wanted to know what will happen in real life, the real world, because this is a randomized control trial, and you know that patients in randomized control trials usually are very well followed up. They are compliant with the medications and so on. But what will happen in the real world, that's another story. For us as clinicians, we always like that information. And here comes, again, an interesting study looking at empagliflozin in real-world effectiveness, the EMPRISE. The EMPRISE is, again, looking at using empagliflozin in routine clinical care settings, with settings that we are using in our clinics when we get patients. So to see the difference between them, when you look at the literature and you review and see the cardiovascular risk in the diabetic patients, you know that approximately 1 in 3 patients with type 2 diabetes will have cardiovascular disease. And in the EMPA-REG outcome study I just mentioned, almost all patients had to have cardiovascular disease. This was a prerequisite for the study. They had to have established cardiovascular disease. Looking at the EMPRISE, it's included, which is very interesting, patients with and patients without cardiovascular disease, diabetics with and without cardiovascular disease. This will show us the benefit in these 2 different groups. The objectives of that study was to assess the effectiveness, safety, and healthcare resource utilization and costs. It's very important in the States, in Europe, not only the safety and efficacy, but also the cost effectiveness. And they are looking at that point using empagliflozin versus one of the very best commonly used DPP-4 inhibitors, which is sitagliptin. So they compared it to sitagliptin in patients with type 2 diabetes. And they looked at the effectiveness, and they decided to look at the first 5 years of use of empagliflozin from 2014 to 2019. And it was planned to include over 200,000 patients by the end of the study. So they included all adults 18 years or above of age, and the ones that would initiate empagliflozin or a DPP-4 inhibitor, namely sitagliptin, between August 2014 and August 2019. And patients had to be, of course, having type 2 diabetes. And the exclusion criteria were patients that already received any of these two agents, whether they switched or they started them before. So these were excluded from that study. And the study design was very carefully designed because it took all patients across the cardiovascular risk continuum, not only those that are at high cardiovascular risk, like the EMPA-REG outcome, but all across the continuum, and looked also at older populations. And it concentrated on new users, patients who are using these drugs for the first time. So in order to make the patients more similar and avoids the confounding factors by switching from one agent to the other to avoid bias. And the comparator, which was chosen to be a DPP-4 inhibitor like sitagliptin, was chosen because it has a similar position in the algorithms for treating diabetes, similar position, similar glycemic efficacy, and similar risk of hypoglycemia, and is generally neutral for cardiovascular risk profile. What was really very interesting is the choice of propensity score matching, one-to-one. When you choose propensity score matching, using more than 140 covariates, you are trying to minimize the bias as much as possible and to reduce confounding by trying to compare patients that are matched almost exactly the same, so they're having the same characteristics. So this will limit the number that you are going to find at the end of the study, but it's very important to be a fair comparison. And the treatment was as treated analysis to avoid any bias to those patients who are non-adherent. The study looked at effectiveness. The primary outcomes included hospital admission for myocardial infarction or stroke, cardiovascular mortality, all-cause mortality, heart failure hospitalization, and 3-point MACE. Secondary outcomes, end-stage renal disease, treatment for retinopathy, or coronary revascularization procedures. Important is safety, because some physicians are concerned usually with safety. They looked at bone fractures, urinary tract cancers, lower limb amputations, severe hypoglycemia, diabetic ketoacidosis, acute kidney injury. And like I said, they are interested in the healthcare resource utilization and costs. If it's cost effective or not, they looked not only for outpatients, but inpatients, and they looked at all different types of costs, not only the cost of medication, but all the costs that would entail hospitalization or even as an outpatient visit. So all these were looked at. This is an interim analysis because it's not till 2019. They took 2 years from 2014 to 2016, so an interim. During these 2 years, again, they had to exclude. They screened 347,000 patients, and they excluded 40,000 because of the exclusion criteria, and they ended up with 306,000 patients. When they applied the one-to-one propensity score matching, like I said, using more than 140 baseline covariates, the number that really matched were 17,593 on both arms, the empagliflozin and the DPP-4 inhibitor. So these are the numbers that we ended up during these 2 years. Looking at the baseline characteristics in these patients, we look at those to compare between it and the EMPA-REG outcome. Those that had history of cardiovascular disease were 25%. The other was 75%, so here it's 1/4. But the different variety of patients, those that had stroke, peripheral arterial disease, heart failures, and it was equally balanced between both arms. The treatment was, again, no difference between both arms receiving antihypertensive, lipid lowering, or other glucose lowering therapy. And when we look at the results and concentrate at the heart failure hospitalization, which is very impressive, and compare the EMPA-REG outcomes, which we showed earlier, and it's impressive, 35% relative risk reduction, we look here with the EMPRISE in the real world, and we find again, it started the benefit very early. You find the curves diverging very early from the very early months, And we have a very impressive relative risk reduction, getting 44% relative risk reduction of heart failure hospitalization. And when you compare it, this was only 24 months. If you stay longer, you will find that the benefit will get longer, because looking at the EMPA-REG outcome, if you compare by 24 months, and then later at 48 months, the benefit is even greater. So looking at the similar effects at other trials, because we know that there are other agents. We know there is the dapagliflozin and canagliflozin with their trials, the DECLARE, TIMI58, and the CANVAS program. And where does the EMPRISE fit with these patients? So when you look at the EMPA-REG, the DECLARE, the CANVAS, and look at the statistics and the benefits, it again matches with the EMPRISE in the real world. So this gives us reassurance again that the heart failure hospitalization reduction we can find in our clinical practice, even in patients without cardiovascular disease, which is already shown below. Even those without cardiovascular disease, you get this reduction. Looking again to compare between the randomized control trial, the EMPA-REG, compared with the EMPRISE, and we look at other parameters, myocardial infarction, stroke, all-cause mortality, coronary revascularization, we find that we achieved with the EMPRISE, when you look at the numbers and the statistics, they go together with the EMPA-REG outcome randomized clinical trial. So it says that you get the same benefit in these patients in your clinical practice. So in conclusion, we have now from the EMPA-REG outcome randomized control trial evidence that empagliflozin reduces the relative risk of heart failure hospitalization by 35% in patients with type 2 diabetes who have established cardiovascular disease. And with the EMPRISE, the real world evidence, we have an interim analysis of 35,000 patients that again proved that empagliflozin was associated with a 44% relative risk reduction of heart failure hospitalization compared to DPP-4 inhibitor like sitagliptin in patients with type 2 diabetes in routine clinical practice. In the EMPRISE, 3/4 of the patients did not have cardiovascular disease. So this again reinforces that the benefit and the effect of empagliflozin on heart failure hospitalization was consistent in patients with and without established cardiovascular disease. And finally, these findings again complement the result of the randomized clinical trial, the EMPA-REG outcome. It again confirms it and indicates that these findings with reduced heart failure hospitalization can be translated into our routine clinical practice using this agent. And I expect, as we are all waiting for the studies studying empagliflozin in heart failure, even in non-diabetics, and looking at those with reduced ejection fraction, like the Emperor reduced study, and preserved ejection fraction, like the Emperor preserved, and these are going to come out hopefully soon. They are going to show us the role of this new molecule as an anti-heart failure medication, irrespective of diabetes. So this is what it's going to. It's going to be used as one of these heart failure medications which you can add on top of ACE inhibitors, beta blockers, mineralocorticoid inhibitors, and so on. So we look forward to this, and time will show. Thank you.
Thank you very much, Professor Ihab. This was very interesting lecture. My interest is that the results of the EMPRISE real-world evidence showed better results than the EMPA-REG, which is the randomized controlled trials regarding the heart failure hospitalization, which gives us more evidence that the drug is superior in this setting in particular. What's your opinion about this? Because the results in the EMPA-REG, I think that the heart failure hospitalization is 35% reduction compared to placebo. While comparing this for an active anti-diabetic drug like sitagliptin, the results reached 44% relative risk reduction.
It's very impressive, because even when we compared them both on the graph, the 44% was after 24 months. I mean, this study is still continuing 3 more years, so it might get even more. When we look at the EMPA-REG outcomes, 35% was after 4 years. So when we look at 24 months, it will even be less. So there is definite difference, definite improvement in the real-world study. And this is very surprising because, like you said, the randomized control trials, the patients are well controlled, they are adherent, they are followed up regularly than in the real-world practice. But these are the statistics, these are the findings. And this shows us that you are going to get benefit, if not equal, but even more in that aspect of heart failure hospitalization. So that's an impressive figure.
Do you think that, I know there is some trials on this group of drugs on heart failure, but do you think that this is a class effect, or there are some differences regarding the higher selectivity of some molecules than the others in this SGL2 inhibitor?
Well, most of the class so far have shown, like I showed in the comparison, they have the same benefits so far, with differences in some had a little bit complications, like the canagliflozin, which was kind of disappointing, although it was very effective. But yes, the other agents so far in their studies have proven to be effective against, especially in heart failure hospitalization reduction. So it's apparent that that class is, but we have to wait because there are at least 5 other agents coming up. Each one has to show its own trial. But the ones that already are available, we have trials that are comparative.
Any question for Professor? تفضل.
Thanks, doctor. If you have a patient with heart failure, someone diabetic, other patient is non-diabetic, the EMPA-REG heart study, the EMPA-REG study concluded that cardiovascular events, whatever mortality, hospitalization of heart failure reduced 30%. In paradigm heart failure, patient heart failure, mortality reduced 20%, I think. If you have patient diabetic and heart failure, would you choose to add Entresto or empagliflozin? And is there any ongoing trials, summation or synergistic effect between Entresto and empagliflozin?
Excellent question, very good question. What I would do personally is I would put both agents, because this is additive. They're not competing. We get different mechanisms of action like we showed, so you're going to get benefit, and you still have a residual mortality. I mean, even though you're reducing the mortality, but there are still residual mortality going on, so why not reduce it further by using evidence-based treatment that we have? So to answer your question, yes, I will add them both together and use them, and I think this is going to be what's coming. As regarding the studies, formal studies, combining them, I'm not aware of anyone going on currently.
I think that one of these molecules in its study, the patients were receiving Entresto.
Yeah, but not as
they were receiving standard care,
including,
yeah.
But not to have in standard care, yes, with an arm that is purely sacubitril valsartan, and an arm purely empagliflozin. But some of them was included as a standard of care. That's different. But she's asking that you compare both. You need to do such a study. Okay, you put these and then you compare them. I don't think it'll be even ethical to do that, because to put the sacubitril valsartan, you will have not to give them ACE inhibitors or ARBs, which is, you cannot do that. So it'll be very difficult to carry such a comparison.
Any other questions? So please join Professor Ihab, and
thank you.
Thank you very much. And it's my pleasure now to introduce my dear friend and eminent speaker, Professor Ahmed Shawqi from Ain Shams University. He will talk about EMPA-REG outcome data across the continuum of cardiovascular and future of empagliflozin in heart failure, which will answer some of the raised question in this session. Thank you.
Okay, yeah. I love the question. The question was very good because and I love the answer. Professor Ihab, طبعا Professor Ihab is my dear professor, and he answered it very elegantly. We don't put RAS inhibition and ARNIs versus SGLT2 inhibitors when we're talking about heart failure. Additive effect, yes, I agree totally that this is, and this has been seen in a trial actually that we do gain benefit when adding an SGLT2 on top even of an ARNI. There is reduction of mortality and heart failure. But we are in a dilemma really actually. We have a problem across the world that diabetes itself is increasing. And in our region, it is becoming an epidemic. If you look here at Egypt, Egypt is one of the most infected or infested countries which increased prevalence of diabetes, which will increase later on. And I think, if I am not mistaken, we're number 10 right now, and we might be number 8 in the amount of patients that have diabetes around the world. And all the countries above us are actually countries which are more populated than us, so it is expected that we have. Not only that, diabetes entails a huge burden, including cardiovascular disease, and atherosclerosis is a huge part of it, and so is heart failure. And we know diabetics by themselves, regardless if they have already an established cardiovascular disease, are more prone to complications, more prone to heart disease, more prone to an impaired ejection fraction and heart failure, and so and so. And this is something we can never deny. This is something we can never run from. And heart failure right now is becoming an epidemic. Believe it or not, the #1 cause of death of diabetes nowadays in the Western countries, after the improvement of managing strokes and myocardial infarction, is actually heart failure. In our countries and the less developed, it is still myocardial infarction and strokes. But in the world, right now, heart failure is becoming a booming epidemic because of its prevalence, and it's increasing more and more, and definitely the #1 cause of death in the Western countries with a better outcome for myocardial infarction. And we know we are talking a lot with sacubitril valsartan and SGLT2 inhibitors about hospitalization. It was actually a marker that has been seen in the saxagliptin, the SAVOR trial, when saxagliptin was compared to placebo for cardiovascular benefit or non-cardiovascular harm. And there was a trend with increase in hospitalization. Hospitalization of heart failure entails increased mortality. Even if it's just the second, third, or fourth, patients will die more when they are hospitalized. And this is something which is very important. Don't take hospitalization as a marker which is not important. It is a huge marker. And it is very important for medications that can reduce this hospitalization, that they will reduce problems in patients with heart failure. And as Professor Ihab just said, we're having still a lot of unmet needs when we're talking about patients with cardiovascular disease. And in heart failure with a reduced ejection fraction, you actually, the question was very nice. Yes, sacubitril valsartan has reduced mortality and hospitalization by 20%. But the mortality of heart failure is still an immense 30% if we're taking the standard of care and following up patients over 5 years. So it is still extremely high, and we're not reaching there. And actually, few patients with heart failure with reduced ejection fraction are getting their tailored, correct, up-titrated doses. And this is another problem that we're facing. Another problem is heart failure with preserved ejection fraction. The problem is not in the disease, it's in the mechanism of what is the mechanism? It's multi-mechanism. That's the problem. We cannot define heart failure with preserved ejection fraction as one entity. It's probably multiple entities. And the other third that we were not looking so much into, which occurs with a lot of diabetics, which occurs with a lot of cardiac patients, is the cardiorenal syndrome. It could start in the heart, end up in the kidneys. It could start in the kidneys, end up in the heart. And we had an interesting session with those with nephrologists and how important the integration between the heart and the kidney can go. And these are key unmet needs that we are still trying to hope to do. The advent of SGLT2s as anti-diabetics, maybe this could change, was very interesting. Instead of acting on the beta cells, instead of incretin-based therapy, they're just helping stop the reabsorption of glucose, thus increasing glucose excretion in the urine. And this reduces blood sugar in our bodies. This mechanism of action reduces the blood sugar, reduces the amount of fluid a little bit in our bodies. It reduces weight and reduces systolic blood pressure. So actually we're having now a medication which is essentially a glucose-lowering medication, but also it is significantly reducing of blood pressure. I'm not talking about 20s and 30s of millimeters of mercury. I'm talking about 5 or 6 or 3 or 4, it depends on the dose. And also losing of the fat mass of the body. This improves outcomes when you also lose weight. And how this cardiorenal protection is going on, is it just only these parameters that we're talking about? No, actually there are many other, and Professor Ehab showed us a big slide on the probability of why these medications will reduce and will reduce heart failure hospitalization due to many mechanisms, and still it is a theory, it's a question, and we will see what will happen when we get more data. And actually empagliflozin and Boehringer are leading the way here with a study that I'm going to tell you about that is going to help us understand how these drugs really benefit our patients of heart failure. Professor Sameh just asked a very good point. Are all SGLT2s the same? And this is a very good question, because yes, they're not the same. We have selectivity, and the highly selective are the EMPA, ER2, and DAPA, with lower selectivity for the CANA, and this might be, I do not have an answer, a problem for the side effects or efficacy. We can discuss that a lot. But again, efficacy always tailors in our minds for any medication reduction of side effects, and this is an important part to be taken. One thing that I want to highlight here, and I know Professor Ehab said it even better, that cardiovascular death is what we are trying to do when we treat all our patients, be it a hypertensive patient, be it a heart failure patient, be it a diabetic patient. And cardiovascular death is quite unique to certain medications. And empagliflozin demonstrated this with a massive 38% relative risk reduction of cardiovascular death on top of the placebo, regardless of blood sugar control. Regardless, nafs blood sugar control, but there is an improvement in cardiovascular death. And this has been seen regardless of the dose, be it the 10, be it the 25 versus placebo, they're actually the same. Not only that, this entails a patient, if you have heart failure to start off with, if you don't have heart failure to start off with, there is reduction of cardiovascular death in both patients. This gives us a little bit of a hint on primary prevention also, not just secondary prevention. And with prevalent or no prevalent chronic kidney disease, do they both benefit? Of course, and this can be seen in this sub-analysis of EMPA-REG. Again, empagliflozin has shown improved outcomes in heart failure patients, in non-heart failure patients, in chronic kidney disease patients, in non-chronic kidney disease patients. In any sum of GFR, I remind you, when these medications came out, we were talking of contraindication with a GFR below 60. But you're going to be amazed by what the data is going to show us. Now they are approved up to 30, and the newer studies, and the one by empagliflozin, will be even till 20. So, did cardiovascular disease and reduction of cardiovascular death happen in one entity of patients? No. If you have single vessel coronary artery disease, if you have multi-vessel coronary artery disease, if you did a CABG, if you had peripheral vascular disease, a history of MI, a history of stroke, a history of heart failure, history of all of these had a significant reduction of cardiovascular death. That means all patients benefit. All patients that are eligible for empagliflozin showed a benefit in the EMPA-REG, and this is a landmark study. Look at the data here. It's consistent with all patients, whether an atherothrombotic event happened or not, whether it was an MI or a stroke, there was a significant reduction by empagliflozin for cardiovascular death. And this was seen again in all. Not only did it reduce cardiovascular death, why am I talking about cardiovascular death? Because actually empagliflozin is the only medication stated in the guidelines, stated in the SGLT2 inhibitors, that it is unique in reducing cardiovascular death. All others are excellent for heart failure hospitalization, but cardiovascular death is really unique for empagliflozin. But it also reduced fatal MI, strokes, death due to heart failure, and this is another endpoint which is really important. So I think you can see if we compare different studies, of course, this is indirect because DECLARE was mainly a primary prevention plus a little bit of secondary. Canvas was more of a secondary, 70 and 30, but again, cardiovascular death was not seen except with EMPA-REG. So this is what happened. The guidelines have changed dramatically. I remember when the EMPA-REG came out in 2015, 2016, the heart failure guidelines of the European Society of Cardiology were the first to change. The first to include empagliflozin, and they said empagliflozin in heart failure patients that are eligible for an SGLT2 inhibitor with reduced ejection fraction to reduce hospitalization and cardiovascular death. So actually, we respect our diabetologists, and they are our good friends and colleagues, but we were very impressed, very happy that we have a medication with sacubitril valsartan that reduced outcomes. And this has implied on so many guidelines, so many different guidelines, be it cardiology, be it diabetology. There are so many guidelines that have given us data that SGLT2s and especially cardiovascular death reduction by empagliflozin as important. If you look at the ADA guidelines that were just published last month, here, if you have a patient who is at high risk of cardiovascular disease, and if heart failure or chronic kidney disease is the predominant problem, here you should write an SGLT2 if the GFR is above 30. Again, remind you, we were talking about 60. They're going down. They're protecting the patients. Their efficacy in glucose lowering may be a little bit less with the lower GFR, but their cardioprotection and their nephroprotection is very prevalent. If you need, even if you need a weight loss, here SGLT2s are extremely important. To minimize hypoglycemia, they're present as a second line. They're just not present if we're talking about cost, because here we know cost, sulfonylureas and TZDs are the most cheaper. So again, here an important. And here in the European Society of Cardiology, and I have to stress this, it was not the cardiologist alone. It was also the European Association of Study of Diabetes. It was also a collaboration with the Diabetes Association. It was not us cardiologists by themselves. It was a collaboration. And they stated to a certain degree that if your patient has heart failure, especially in drug naive, we can even skip metformin and start with an SGLT2 for heart failure patients because of their outstanding benefit. I remind you, metformin reduces heart failure problems. It's a class 2. But empagliflozin and also other SGLT2s reduce it as a class 1. And probably most of our patients are going to take combination therapy in diabetes. So we're not skipping. We're just showing which are the most important, and this is another thing that we should take into consideration. And of course, even if the patient is on metformin, SGLT2s are really important. And here is the differentiating part of guidelines. Empagliflozin, canagliflozin, dapagliflozin are recommended in type 2 diabetes and cardiovascular disease at high or very high risk. We're talking about prevention again. But empagliflozin is the only one mentioned when you have to reduce the risk of death, of cardiovascular death. It's empagliflozin because of the EMPA-REG, and this is really important to take into consideration. Heart failure, again, it's a class 1A. Look at the data. The data is compelling. The level of the class of recommendation is class 1. This is not something to debate. This is something which is correct and we have to do, not we may be considered or should consider. This is we have to do. So what is coming in the coming years? Well, there's a lot. Empagliflozin, and actually I have to say also dapagliflozin, because the question was asked. Actually, if we look at the data coming from other SGLT2s, we have ertugliflozin with just a cardiovascular protection. They don't have a dedicated heart failure program. We see canagliflozin, no data, but actually empagliflozin are very active in this part, and also, to be truthful, also dapagliflozin. But the data here presented by empagliflozin was fast-tracked by the US FDA for trials to envision how we can treat not only heart failure with a reduced ejection fraction, but also heart failure with preserved. It includes the emperor, whether in the reduced ejection fraction, preserved ejection fraction, the imperial, which is partly data we can hear about, and the EMPA-vision, which is going to be groundbreaking, because this will look at what mechanisms probably are the benefit of SGLT2 inhibitors are coming from. The imperial, which was mainly due to looking at functional capacity, which is a surrogate endpoint. It's important, but it's not that important. But again, looking at that, whether in reduced or preserved, and we're hearing some data coming out as we go. But the most important here is the emperor. The emperor is one of the most important trials in heart failure. Why is that? Because we're looking at patient outcomes. It is comparative to the paradigm heart failure study, whether it's in reduced, and the paragon when we're talking about preserved. Any patient, and look at this first line, including, that was your question, with or without type 2 diabetes. These medications are invading non-diabetic patients too. Those with a reduced ejection fraction, those above 40 is considered preserved, as in most trials. Not only that, anybody with a GFR not 60, not below 30, below 20, and this is a landmark study when we're talking about the reduction of GFRs. I remind you, it was 60, going to 45, going to 30, and now even maybe 20 if the data here is improving outcomes. This is really important. Of course, acute heart failure is not, because this is talking about chronic heart failure, which is a big problem. And of course, acute heart failure will probably need a huge amount of diuretics. Again, an SGLT2 and diuretics are not a very preferred combination because they might do a little bit of problems. What are we looking for? We're not looking for comparison versus placebo. We're looking for comparison versus the standard of care. Maximum dose RAS inhibitors, beta blockers, and the follow-up is an estimated of 3 years and plus for those with reduced, with those with preserved. And if you add up the numbers, they're very close to the paradigm heart failure, which is the biggest heart failure study till now. And the follow-up includes important markers. It's not just quality of life, it is cardiovascular death. It's hospitalization due to heart failure. Those things that will reduce mortality in our patients. Those things which improve our patient outcomes. Those things which are endpoints that we should really look for. And of course, there are secondary endpoints like quality of care, Kansas City cardiomyopathy questionnaire, and those with an eGFR preference, because there is an improvement of outcomes with lower GFRs and in chronic kidney disease. But this is the one I'm really, really interested in. I think this is my personal view, regardless of anything. These emperor would probably be a little bit of positive, definitely. But this is something which I really want. Professor Ehab showed us maybe 16 or 17 causes, theories, possibilities that SGLT2s improve heart failure. But here, this is a very important and a landmark trial again, EMPA-Vision. What are we looking for? What is the mechanism that these drugs improve heart failure patients? Here, it is not just theory. Here, it is CMR, cardiac magnetic resonance imaging, exercise testing, cardiopulmonary exercise testing, and assessment of cardiac metabolism, energetics. There are preliminary data on empagliflozin and DAPA on that part too. But here, this is a controlled study to show the mechanism of action of these medications. And when there is a proof, I think they can be catapulted higher up in heart failure guidelines in 2021. And this will include all patients, whether preserved ejection fraction or reduced. And this will help us, even with other medications, understand probably the problems that occur in preserved ejection fraction, and will help us show why some medications work, why some medications don't work. The only contraindications if the patient has a contraindication for an MRI. We need accurate assessment of how the mechanism works. So all patients will undergo an MRI and a cardiopulmonary exercise test. So if we cannot do that, okay. Number two, an eGFR of below 30. So data here will be extremely impressive and really will highlight how these medications are doing the wonder they're doing really. So actually, I quoted this from previous lectures, and us as cardiologists are looking at it from this way, and so are the nephrologists actually. It's not just the cardiologists. We think SGLT2s are more than just glucose lowering medications. We're talking about drugs that protect the heart. We're talking about drugs that all show protection of the kidneys, and they just lower glucose too. But definite protection data is extreme in these medications. So my take-home message, sorry, I still have 4 minutes. معلش الماوس بقى. My take-home messages is that diabetes, as shown, diabetes, as shown, is still a hugely debilitating disease. It's increasing worldwide. Still, the #1 cause of death is myocardial infarction and strokes in our patients. In the Western countries, it's mainly heart failure because the better outcome of studies now on medications and primary PCI done for those with myocardial infarction and strokes. The hospitalization was not just a start, it was started, of course, by saxagliptin in the SAVOR trial. And now, instead of a trial that showed non-inferiority by empagliflozin in the EMPA-REG, it showed a superiority for heart failure hospitalization. Empagliflozin also showed us the only SGLT2 with a guideline indication to reduce cardiovascular death. How do these mechanisms work? Do they work in heart failure? We're looking forward to the EMPEROR studies, whether in preserved or reduced ejection fraction. But how do they work? This is the only study that I know of that is looking on the mechanism of action, and this is the EMPA-Vision, and we'll be very delighted to see what happens. Thank you so much.
This was very interesting, Professor Ahmed. As usual, it's an excellent talk.
Thank you, sir.
And I am impressed actually by the reduction in the cardiovascular mortality. But was impressed also that the drugs are used for a lower GFR because there was a claim that they are not working in the lower GFR, but they are using up to less 20 GFR. So this denies the claims that were talking about the mechanism of action of these drugs. And also the renal outcomes for these drugs are very impressive. So I think they are going to, this will be the future in the treatments, whether for diabetes, for cardiovascular protection, or even for heart failure.
Yes, I agree totally.
No, it's, you summarize it all. It's, you have the benefits all through the cardiorenal syndrome. It also reduces albuminuria, which is very impressive, and reduces the risk because they were trying to scare us before from that drug age group all because of the renal impairment, and it's going to injure the kidney and take care, but it turned out the other way. It is actually protective, and you have to know how to use it. It's very impressive. Like I said, it's going to be one of the cardiologist drugs irrespective of type 2 diabetes eventually, and maybe the nephrologist as well will wait and see. And we'll wait for the mechanisms to, because it's very interesting to find the mechanism in these disorders, especially with the preserved ejection fraction, which we have nothing yet proven to give to these patients. So we hope this will translate into some benefit.
Hopefully.
Thank you. Any?
Thank you, Dr. Ahmed. This was very nice.
Thank you.
You showed clearly from the guidelines that the positioning of this group of drugs are in patients with very high cardiovascular risk and high cardiovascular risk. My question, what is the position of this group of drugs in patients according to risk scores who are considered at low or moderate cardiovascular risk?
Okay, low or moderate cardiovascular risk, and you don't want any hypoglycemia, here we can standardize that DPP-4s, metformin, SGLT2s, all of them can be given, and GLP-1 agonists. You will put into consideration the benefit for the patient. You will put in consideration weight loss. If there's weight loss, it is SGLT2s, definitely, or liraglutide also loses weight. If you're looking at cost is looking at sulfonylureas and TZDs. TZDs, actually, pioglitazone reduces strokes but increases heart failure. It depends. I think all options are optimal, but if you have high or very high, I think now it's a class 1, you should give an SGLT2.
Also, when you saw the data that I showed, again from the real world data, and it included the patients who do not have any established cardiovascular disease, not even low risk, they do not have. And they showed the same benefit exactly as those with high risk. So even those without established cardiovascular disease have the same benefit, and this is the value of the real world data in comparison to the EMPA-REG outcome. So we have confirmation, Doctor.
Thank you, Dr. Ahmed.
The EMPA-REG also included patients with the 4 categories of risk, the low and the intermediate and the high and very high risk patients with different percentages. But the EMPA-REG outcomes have the same different risk categories for the but the benefit is for all the risk.
But if you have heart failure and the patient is not for high cardiovascular risk, it's just heart failure, remind yourselves, heart failure is not present in risk stratification by the score. This is class 1 too.
Thank you, Dr. Ahmed. Is there solid evidence in follow-up in prognosis in patient with diabetes mellitus using empagliflozin, like مثلا N-terminal pro-BNP, ejection fraction, cancer stage questionnaire, glomerular filtration rate?
This will be answered with Emperor, whether it's in the preserved or the reduced arms. This will be actually a very good thing because they started off with Imperial, which is really 6-minute walk test, mainly things which are not hard to take into consideration. But Emperor will answer all the ones you came up with. All these questions will be answered definitely.
Any other questions? So by the end of this, I would like to thank Professor Ihab Ataya and Professor Ahmed Shawqi for their very excellent presentations, and we invite the next session chairman.
نجيبهم صح؟ الليزر.
سامعني كده؟ الو الو. ايوه انت سامعني كده؟ الو. ايوه. لا انا مش سامعه، صوته مش جاي لي. لا صوته مش جاي لي. لا الصوت مش جاي لي يا ريس. الو الو الو. طب هو سامعني طيب؟ مش سامعني؟ احنا كده. سامعني كده؟ الو. سامعني؟ سامعني؟ انت كده صوتي جالك كده؟
يلا يا باشا. ايوه يا ريس.
انا كده الو اتكلم كده، اقول له اتكلم كده يا بابي. محمد سامعني يا محمد؟
والله
ايوه يا محمد. محمد سامعني؟ ايوه يا محمد. صباح الخير يا محمد.
عامل ايه؟
الحمد لله تمام. علي صوتك كده من عندك شويه يا محمد. اتكلم كده. محمد ابراهيم.
دكتور سيد
ايوه محمد سامعني؟
اللي واطي قوي يا عبد.
انت سامعني كده يا محمد؟
صوتك بعيد. انا بكلمك على حاضر.
محمد ماشي
يا مصطفى، يا عم مصطفى سيد.
ايوه محمد سامعني؟ بسم الله الرحمن الرحيم.
سامعك على
ايه؟
سلام خبرك.
انا سامعك يا محمد، انت سامعني؟ محمد
هم هنا بيفتحوا الشارع
يا محمد.
خلاص.
الو تيست 1 2 3 4 سامعني يا محمد؟
ايوه
ايوه يا محمد سامعني انت كده؟
يا ريس انا فلت الفيس والله.
اتكلم في الانجليزي. الو يا محمد. محمد ابراهيم يا مبابي.
ايوه
يا محمد سامعني؟
يا اتفضل.
محمد
والله لابس فيس كلهم لابس فيس. ايوه مش سامع عليه حاجه
يا مبابي.
الفيس على الاخر.
يا مبابي.
عليكم السلام ورحمه الله وبركاته. هندسه سؤال اخبارك ايه؟
طب انت قول لي انت سامعني في العربيه؟ طيب انت سامعني في العربيه؟ افصل الخط من عندك عم. اقفل السماعه عندك عشان الخط فصل. اقفل السماعه عشان الخط فصل. اكلمك تاني كده. انا بتصل كده يا عم مصطفى. الو يا محمد ابراهيم.
ايوه بقى كده.
ايوه انا سامع محمد عندي يا عم مصطفى.
يا عم سيد.
ايوه يا محمد سامعني؟
كده كده سمعتك كويس، سامع نفسي كمان.
تمام بسم الله الرحمن الرحيم. سامعني 1 2 3 4.
1 2 3 صوت عالي قوي على السماعات عندك يا سيد.
الصوت طب ماشي هنزل لك بيه اهو. طيب بسم الله الرحمن الرحيم. اتكلم كده يا محمد طبعا عشان اظبط معاك.
الله 1 2 3 4 5 1 2 3.
ايوه يا محمد سامعني كده يا محمد كويس؟
سامعك كويس يا سيد، صوتك كويس معايا وبس الصوت عالي قوي عندي.
ماشي
على السماعات عالي قوي.
طيب ماشي. هو احنا بس عشان كده انا بكلمك من الهايبرد، لكن هيظبط معاك في الساتلايت زي امبارح بالظبط.
طيب ماشي نظبطها بقى مع بعض.
خلاص ماشي يا باشا. شكرا يا محمد.
ماشي.
انت سامعني تمام كده؟ في راجع عندك ولا اي حاجه؟
لا راجع بس لما انا بتكلم.
تمام يا باشا.
ماشي.
مصطفى بيكلمك يا محمد.
لا مش سامع حاجه على الارفيس، انا سامعك انت بس يا سيد. كده سمعتك قول. طيب ماشي كده 1 2 تمام.
عم مصطفى
جاهزين ايه؟ لسه الاجهزه بتشتغل يا عم مصطفى. طيب ماشي.
افصل انا كده خلاص؟
كده الصور كلها معانا؟
شكرا. انت حاطط الكابلين منين؟ يعني ده معاك باك اب مثلا؟ معايا ده ومعايا ده. الله يبارك لك. سامعني؟ ماشي يا باشا انا هسحب الخط ها.
ايوه ايوه
يلا يا باشا.
ايوه
ايوه معاك.
سامعني يا عم مصطفى؟
انا محمد مصطفى الدكاتره معاك. انت
انا وسام حاجه يا دكتور، احنا بنتست بس بان القاعه اللي يبقى فيها اللايف ترانسميشن ان شاء الله.
انا يا باشا.
حضرتك سامعني كويس؟
عايز هنا كان في كتير عايز بره كوكتيل فين؟ بص استنى تعال نعرف نشتغل على السيستم نقدر نشتغلها؟ ها؟ نعرف نشتغل طول السيستم نشتغلها؟ عشرة يا كريم. ها؟ طيب خلاص يقول 4. الله ينور. الله ينور. يو 4 وعملت هاتي بقى فوق الضغط والقصه ابيض فوق الضغط. هات يا باشا هات اسمه ايه ده الجايدنج بي 4 بي 4 بي 4
يعني احنا لينا ربع ساعه زياده عن الساعه، ناخدها قبلها نتست بيها ولا ناخدها بعدها عشان لو العمليه
هاخدها لوحدي. معانا ربع ساعه كده. صح لا ايوه صح طبعا.
بص يا عم مصطفى
كويس كويس اوكي كويس حاجه قبل ما اخد اليوم ده
هو عايز حد مننا ياخد
مفيش حد معاكم انتوا؟ طيب اما هو بيتكلم هو لابس هو كلمه كده.
احمد سامي، حضرتك سامعني يا سامي؟
انا سامعك كويس.
طب انت صوتي واضح عندك؟
نعم واضح انت يا واضح احنا صوتنا واضح عند حضرتك.
هو يعني ممكن حضرتك تتكلم شويه يعني دقيقه مثلا ولا حاجه؟ او عد حضرتك 1 2 3 4.
1 2 3 4. مين معايا طيب استاذ مين؟
دكتور ادهم رجب من الشركه المنظمه.
دكتور مين؟
ادهم رجب من الشركه المنظمه.
انا دكتور ادهم.
انا سامع حضرتك.
انا مدرس حضرتك سامعني؟ وعندي دكتور نبيل برضه.
دكتور حضرتك ممكن تكمل كلامك كده؟ بنتست بس.
الصوت اللي جاي من عندكم يا جماعه مش حلو. في انترابشن في الصوت كتير تقطيع يعني. طيب
دكتور حضرتك كده سامعني؟
سامعك بس تقطيع وانت بتتكلم.
انا رايي كده يعني انا بس المهم ان هو سامعك كويس، بس اهم عندي دلوقتي ده
عندنا الدروب كل وقعدت فين المانيفولد؟ انا عايز مانيفولد يا جماعه. هات مانيفولد. لا ده مش مانيفولد ده واي. انا عايز مانيفولد اقدر اطبق حاجه. واقفين على الواي. طب يا بنت كده هدل الاول يلا سايك استاذ خليك مركز معانا معلش كويس بعدين الحاجات الدول انفكشن هنحمي من ناحيتين ما تحركش الترابيزه صغر هات لي تاني لو سمحت اسمه ايه ده هات ده بس هنا وهات تحت
هو انا بقى كنت بكلم باشمهندس سيف ما ركزتش معاك معلش. طيب هو اتحرك من جنبي. هو الصوت كان جاي يا باشمهندس. هو هنا اللي بيسمع. طيب هو سامع هناك كويس يا ريس؟ اه ايوه 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 تمام تمام تمام. مديها اه اه طيب ماشي. طيب ممكن نقلل الجين اللي داخل على الهايبر سنه صغيره. ايوه 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 كده تمام.
وقتی
بسم
اعلام
الله الرحمن
کردم
الرحیم. تمام تمام خلاص تمام.
خیالم راحت شد. ناگهان صدای تمام آژیرها قطع شد. تیراندازی ها متوقف شد و همه جا ساکت شد.
یه نفر یه پرچم رو تکون داد و من از جام پا شدم و راه افتادم.
Test mic, test mic, test mic, test mic, test.
ثانيه
نبتدي نعمل ريفرس.
طب ما حضرتك لسه قال هو صار كان عايز نعمل
يو هاف تو ستارت لايف.
لا
طلعنا وبعدين عادي
يقعدوا يعملوا كده
وانت في الدسكشن وبعدين هتخلص الدسكشن. هو حضرتك عايز تدسكش مع البانل. طب وانتوا ليه تبتدوا تحاولوا شويه؟ لا احنا مش بنحاول انتجريت، انا اضطر نستخدم مايكرو فرنش عشان نحط ايفون مايكرو كاتيتر. انا مش عايز استخدم كمان دلوقتي محتاجه معاك 7 فرنش وفي الوقت حتى لو عديت الايبس بروجرام كاب لسه التارجت نوت جود. فالبوسيبيليتي انت برضه يعني بالظبط يعني تلاند طب this is very hard. فبالتالي عايز اخسر القصه اللي عندي، خاصه ان انا عندي an excellent system connection. دي اهم حاجه.
في وقت 3
دي اهم حاجه.
ودي شفت الواير
اوتومايزيشن بتاعتنا عندنا بايفوريشن كده كده احنا we have all options يعني.
عايزين نعمل فلاش وعايزين نعمل فلاش دايما يبقى في فلاش في
وريني الرايت بعد اذنك.
وريني الرايت بعد اذنك يا باشا. هات لي فلاش.
سيف بس ولا عندنا عندنا اسمه ايه ده عندنا
فتره طويله بيبقى ثرومبوجينيك
اي سي تي.
الجهاز
موجود عندنا.
الجهاز اهو.
يلا يا باشا.
الجهاز اهو شغال.
الحاجات بتاعت الاي سي تي موجوده هناك في الدولاب عندي يا
الجهاز اهو.
الكيتس شوف عندي ايهاب كده وعندي. يلا يا باشا
ان احنا جايدد باي اس تي.
يلا يا باشا بسرعه. يلا عندي مين؟ شوف عندي ايهاب او عندي. شوف بسرعه يعني خلص.
دكتور نبيل.
ايوه انا دكتور نبيل حضرتك سامع؟ سامع. هما
دكتور نبيل
اتكلم كده تاني. ايوه سامعني.
دكتور نبيل
حضرتك قرب السماعه. الدكتور نبيل سامعك بس انت مش سامعه.
انت مش سامعني.
لا
انت مش سامع يا دكتور نبيل.
انا سامعك.
دكتور طارق.
ايوه مع حضرتك. انا سامعني ولا مش سامعني؟
انا سامع حضرتك كويس. انا اشرف بدوي.
اشرف باشا ايه الاخبار؟ الدكتور
تمام.
نبيل مش
احنا
سامعك.
ان شاء الله هنكون لايف في خلال 10 دقائق من دلوقتي.
احنا وي ار ريدي خلاص.
احنا جاهزين يا اشرف.
على ميعادنا يا فندم. شكرا جزيلا. مع حضرتك لايف لحد ما نبدا.
انت سامعني؟
انا سامع حضرتك كويس.
انا مش سامعني الاول.
طيب دلوقتي احنا هيستوري سريعا كده.
اوكي تعالى هنا حضرتك. جاهز اللابتوب؟ جاهز. نعم عندنا 63 years old male smoker for 20 years hypertensive C positive lives in Tanta working as a worker married with 5 offsprings.
دكتور احنا لسه مش لايف. احنا لسه مش لسه الناس ما دخلتش القاعه.
ايوه لا انا عارف انا عارف I know.
ارجع تاني بس.
ايوه
اتش سي في بوزيتيف ماشي. اوكي.
في فلاشات
سي سي اس ماشي. اكسلريتد بقى يعني بعد كده.
ejection fraction 6% مفيش سيجمنت.
اكسلريتد بس لازم تكتب انها اكسلريتد كلاس 3 في اخر اسبوع اللي هو براير للكورونري انجيو.
هنشتغل هو كبير باين.
دكتور نبيل ممكن حضرتك تريح خالص المايكرو كاتيتر بره السيستم حتى لو حضرتك حبيت تخليه في الجايدنج عشان بس ان حضرتك ايه نبقى ما عندناش مشكله ولا خلاص. ماشي اوكي مفيش مشكله.
تعالى
تمام.
ممكن هي دي المشكله اللي هي كل شويه.
قول يا باشا. اي سي جي نورمال. ايكو نورمال.
ايكو نورمال. patients on.
اللاب بتاعه فين؟ اللاب.
اوكي حاضر هحطها.
بعد كده اللاب.
حاضر هحطها حاضر. هنا كانت نور.
دكتور نبيل حضرتك سامعنا كده كويس؟
انا كده سامعك كويس. سامعني انت؟
ممتاز جدا يا دكتور، شكرا جزيلا.
طب هايل.
ماشي. الجي اف ار بتاعه حاجه و90. ماشي يا باشا. اسمه ايه ده؟ هيموجلوبين A1C 5.5.
حاضر.
يلا بقى مش مهم. جي اف ار 90 خلاص مش هتفرق بقى يعني. ماشي يا باشا. هات لطفي. هتعرف تعمل الاي سي تي؟ ها؟
ايه؟
هتعرف تعمل الاي سي تي؟ مين بيعرف يعمل الاي سي تي؟
ماشي انا هعرف اعمله. هات مثلا اسحب بقى. محمد اسحب وهنوصل الجهاز. هنعمله هنا. ايه يا باشا؟ ماشي.
لا يعني بس فضي لي الحته دي عشان دي الوايرات اللي هشتغل منها.
حاضر. مين مع محمد؟ خلاص هو مع محمد. خلي معاك الكيتس كيت باي كيت. اسحب منها. من اي حاجه.
احنا بس هنسحب الوايرات سنه ويستارت كذا.
بس
ماشي اوكي.
نخلي التيب بتاعت المايكرو كاستر جوه.
دلوقتي يلا.
ولا اي حاجه بره خالص. حركه زق الواير هيخش لوحده. ما دخلش هناخد البتاع التاني خلاص. ما تقلقش.
ايوه بتسحب لغايه هنا. يلا
وريني كده نهايه المايكرو كاستر.
يلا يا بيه.
طب معلش يا دكتور طارق، انت هنا التشويس بتاعك انك تعمل ريفرس كارت.
نعم.
هتعمل ريفرس كارت.
هنعمل ايضا يعني ترو تو ترو. لو قدرنا ما قدرناش هنعمل ريفرس كارت خلاص.
حته صغيره.
هات لي سرنجه ثانيه معلش. فضي دي اللي هتاخد فيها البلاد. هات لي 5 سم ثاني من البلوك. يلا. البس جوانتي. خد مني السرنجه دي. يلا يا باشا. اديله السرنجه دي. اهي.
يلا خدها. البس الجوانتي تاني بس.
يلا يا باشا قيس.
حط. ستارت.
دكتور طارق، دكتور نبيل، ازي حضرتك؟ انا محمد فوزي. ان شاء الله بقى معاكم لغايه ما باقي الجروب. اهلا بيكم ان شاء الله.
حد يزق لي بس السماعه.
احنا بدانا.
كويس
كده.
بداتوا ايه؟
اوكي.
ازيك يا دكتور؟ لسه بس الجروب الباقي جايين. احنا الحلقه بدانا بقالنا فتره ولا جاست ناو؟
احنا جاست حطينا التو جايدنج وصورنا ويعني وي ار ريدي وحطينا المايكرو كاثيترز بتاعتنا والوايرات. فوي ار ريدي يعني.
اوكي ليتس ستارت.
اوكي وكان ستارت نو بروبلم.
اوكي كويس كده. هايل كده. بدات اسمع يا راجل.
في ريزومي عن الحاله.
اوكي احمد.
ايوه اوكي.
انت احنا
هنركز بس على الهيستوري بعد اذنكم.
الاودينس يعني اباوت 5 minutes كده هم هيبقوا يعني اتندنج يعني خلال 5 دقايق. هم يعني ليتس بريبير 5 دقايق. هم الدكتور اشرف
يعني احنا بريفلي
لما تبقوا جاهزين
ميدل ايجد فيميل
اوكي
with accelerated angina has a CTO of the mid LAD with a bifurcational lesion in the left circumflex. syntax score بتاعه 19.5 والبيشنت يعني refusing cabbage totally preferring PCI. We have already a syntax score of 19.5 so we have a class 1 indication for both.
اوكي.
He is not diabetic, he is hypertensive and smoker.
Just hypertensive. Okay.
Yes, and smoker.
الجيتسو سكور بتاعها
لسه قدامهم 5 minutes على ما يجي الناس. بس انا بديله
فكره.
فكره.
تشير بيرسون
دول تشير بيرسون دكتور محمد فوزي.
محمد فوزي
ماشي.
الناس اباوت
في تشير بيرسونز تاني وصلوا يا محمد؟
لا لسه ما اباوت يعني خلاص جاي داخلين يعني.
اوكي
ان شاء الله.
خلاص نستنى.
طيب مين اللي تشير بيرسون بس عشان نبقى عارفين؟
المفروض في البانل دي دكتور احمد نصار، دكتوره نارين، دكتور وليد العوضي، دكتور محمد فوزي. صح كده؟ في حد تاني I missed someone else؟
مصطفى مقرب برضو في الطريق يعني.
دكتور مصطفى مقرب.
اوكي.
بس حضرتك ما يجي بس حضرتك قول لنا عشان ندي بس بريف
هو
هيستوري
بس
تاني.
الكاميرا هتبقى على الكمبيوتر علشان يشوفوا
بس احنا الاول انا هانتروديوس الناس اللي موجودين.
ماشي اوكي.
وبعد كده هنعرض بص ترتيب. هانتروديوس الناس. بعد كده الكيس برزنتيشن وبعد كده الانجيو وبعد كده استراتيجي
هو لسه احنا ما جيناش 3 قصدي.
يعني قدامنا 3 minutes to start ان شاء الله.
3 minutes we are ready. اوكي مفيش مشكله خلاص. we are ready.
لسه ما جيناش 3 لسه الساعه 3 الا. فاحنا
هم اللي بيكلمونا هم بيقولوا لنا. احنا هنبدا لما يقولوا لنا احنا.
الهيستوري هتعرف تنقله على كده؟ ماشي. ما نقول يعني خلاص تمام اوكي ماشي.
دي اول حاله النهارده تنام عند حضرتك دكتور نبيل؟ دي اول حاله؟
دي تاني حاله من الدمرداش. امبارح كان في حاله كونجنتال لايف والنهارده دي حاله CTO وبايفوركيشن.
دكتور احمد نصار وصل.
نبيل احنا مش سامعين. انا احمد نصار يا نبيل احنا مش سامعين.
دكتور احمد سامعني كده يا فندم؟
كده سامعينك انت بس الحد بيتكلم مش سامعينه بيعرض الحلقه.
لا ما حدش بيتكلم دكتور احمد.
اوكي طب
انا
يلا
طارق حضرتك سامعني؟
سامعك كويس.
طب
اوكي يا ماشي.
ريدي ار يو ريدي احنا
لسه 5 دقايق يا دكتور نبيل بالظبط 5 دقايق.
طب اوكي.
هيكمل.
طب لما تبقوا جاهزين قول لي وعشان نقدم الناس اللي معايا وبعد كده نقدم الحاله.
اوكي ان شاء الله.
كامل ACT 200 لسه ACT
معلش بس هو احنا
ACT ستيل كاونت.
انت جايب الكاميرا
اصبر على ACT.
دي مش كاميرا هي اللابتوب نفسه على واحد اللي على طول.
اوكي.
السلايدز ونتكلم. هم هيبصوا حضرتك في المايك
وانا هقلل السلايدز. اوكي.
انا بس نبيل هو احنا القاعه ما فيهاش فورينرز فهنتكلم كده براحتنا يعني.
ممكن نتكلم. طب اوكي هاي.
اوكي اللي انا عايز اقول لك عليه ان انا منوطه CTO مان.
يس احنا هنشرح كل حاجه ببساطه شديده يا دكتور احمد.
فانا
احنا كمان
ليا ماي اون فيجن وماي اون بوليسي وانت عارف الكلام دوت وطارق برضو عارف كده. فاحنا ويل جوينج بس نشوف البرزنتيشن ايه وهتقولوا لنا ايه لكن هنناقشكم از ماتش از وي كان بعنف شويه.
يا دي طبعا كل اللي انت عايز تساله لنا يا دكتور احمد تساله لنا احنا اوريدي يعني.
اوكي. بيتهيألي دلوقتي اتس اولموست 3 شارب فيو كان ستارت.
Okay, I can start now. Let's first introduce Dr. Tariq Rashid. Dr. Tariq Rashid is the assistant professor of cardiology here in Ain Shams University, and Dr. Tariq is one of the best CTO interventionists, not only in Egypt but also in the Middle East. We have also Dr. Ahmed Hatata, دينامو معانا شغال. معايا أستاذ سيد technician, أستاذ رمضان ومحمد لطفي النيرسينج اسيستنت معانا. احمد حتاتا هيقدم الحاله وبعد كده احنا وي كان اوبن وهنشوف الانجيو بتاعها وي كان اوبن الدسكشن نعمل لها ايه. اتفضل يا احمد.
Okay. Good evening, Dr. Ahmed. Our case for today is a 63-year-old male. He is a smoker for the past 20 years. He is hypertensive, FC positive. He lives in Tanta, working as a worker, married with 5 offsprings. His complaint is exertional angina, CCS class 2 for the past 6 months, accelerating within the past 3 weeks. His ECG is within normal sinus rhythm, echo ejection fraction 60%, with no resting segmental motion abnormality, diastolic function grade 1, with mild mitral regurgitation and mild tricuspid regurgitation. Patient kept on aspirin, clopidogrel, statins 40 mg, candesartan 8 mg, and nipivirol 2.5 milligram. His laboratory serum creatinine 1.1 with estimated GFR 90. His hemoglobin A1C is 5.5. His hemoglobin is 12.9. He did a coronary angiography on the January 2020. He has a mid-total LAD filling retrograde from the right coronary artery. He has a mid-subtotal lesion in left circumflex, bifurcating in left circumflex and OM branch. He has large right coronary dominant artery with mild lesion in its mid-segment. If we see the angio after this, we can calculate the syntax score is 19.5, so CABG is class 1 and PCI is class 1. His GCTO score is 3. And the items length more than 20 millimeter, ambiguous stump of the proximal cap with degree of calcification. There is no previous trials, and there is no bending more than 45 degrees. This is the other item, the GCTO score. Patient refused CABG, so the patient was referred to PCI. Okay, now we will transfer to Dr. Tariq and Dr. Nabil with the angio.
Wait for a moment. We need
Dr.
to
Ahmed,
discuss
yes.
the presentation.
Yes.
To start with, the patient is not on adequate medical treatment. Don't you agree?
Yes. Yes.
Okay, so why didn't you
but
try
now he's
to
on adequate medical treatment. Now
let's Dr. Ahmed بس say something that the patient already has an angiography done before, and the angio showed a two-vessel disease, totally occluded LAD, and LAD is a very important one of the criteria to do intervention when we find an LAD occlusion. If the circumflex or the right coronary is totally occluded, we can do some tests to justify intervention, but the LAD is different. At the same time, this gentleman has an angina, is symptomatic, and his LV function is normal. And this is all of these are criteria for patient selection for CTO intervention in such case. He has, in addition, a circumflex artery with a bifurcation lesion, Medina 111, including circumflex and a sizable obtuse marginal branch.
Okay. And this morning we were discussing, me and you, about the the stability of patients with preserved LV systolic functions. And if this patient responding to adequate medical treatment, what will be your decision?
Dr. Ahmed, احنا في algorithm, we are following this algorithm in case of the patients who are having CTO, and this is an international algorithm. Patients who have chronic total occlusion, if they are symptomatic and if the LV function is normal, I know that he's symptomatic in spite he's not taking optimal medical therapy. But this total occlusion, we know that the total occlusion is involving the LAD, and LAD is a very important artery. If we do a stress imaging for such a patient, definitely will have a large perfusion defect, more than 10, because he has the LAD totally occluded and a circumflex, a critical bifurcation lesion. Definitely the area of myocardium geoparty in this special case is large. And in this condition, intervention will be much better than even optimal medical therapy. طبعا definitely we combine both optimal medical therapy and intervention.
Okay. Go ahead.
Let's demonstrate the angiography, and I would like to see your opinion about which strategy we choose. This is a BA cranial showing a totally occluded LAD, and actually we couldn't see a stump.
Yes.
And there is a big septal branch as a continuation of the LAD. This is exactly what we call an ambiguous stump.
Sure.
When we do a dual injection, next.
بعد كده.
Next.
بعد كده.
I would like to emphasize that we have to put a safety wire in the donor artery. Even if we are going to do antegrade approach, we have to put a wire in the donor artery to protect this donor artery from dissection or something that may happen from the guiding caster. Because we are using an Amblitz left guiding caster for the right and XB guiding caster for the left. And as you see, Dr. Ahmed, that there is a good septal collateral to the LAD. The length of occlusion is very long. The LAD distal to the occlusion is diffusely diseased within this ambiguous stump and calcification. All of these are criteria of failure of antegrade approach in a such case. Ambiguous stump, a very long occlusion. The distal part of the LAD distal to the occlusion is diffusely diseased, and the presence of calcification. One that encourages us to do it retrogradely, or a decision to retrograde approach from the start, is we have a very good septal collateral supplying the LAD as we see in this angiography. طارق لو يحب يعلق.
Yes, I totally agree with Dr. Nabil. We have an ambiguous proximal cap, so you can define this cap easily. You have to put an IVUS to take an 8 French guide because you will add IVUS with the microcatheter within the guiding. We'll advance both, so we will need an 8 French guiding. Second thing, if we demonstrated the cap by IVUS, the most big problem is the distal target. Distal target here is not good and diseased with this very long segment, so the chance for going even subintimal after going to the cap is very high. And we need to preserve the true lumen all through the LAD because it's a very important vessel. So here there is a big chance to go in the subintimal space. And we have, as Dr. Nabil said, an excellent collateral going retrogradely. Although this collateral is a dependent collateral, the patient depends on this collateral for the supply of the LAD, and he might experience chest pain while you are working. But we prefer to go through this collateral because it's an easy one, and we don't want to complicate things. We have another collateral, but if we are going to tackle this collateral, the procedure will be too lengthy, and we will use a lot of contrast, and of course radiation will be much higher than expected. So here I think primary retrograde is a good option because we have a bad distal target or poor distal target, ambiguous stump and long segment with a calcification. So we are waiting for your comments, please.
I think Tariq and Mohammed Hosni, I think are justified enough to go retrograde because it will be a little bit easy for you because of the GT score is relatively high and the segment is long and the ambiguous cap, and I totally agree with you to go retrograde from the start.
So Mohammed, you agree to do it retrogradely, and the decision of retrograde approach from the start is a correct one.
Yes, unless if you are go antegrade, IVUS guided, and it will consume time and go for higher French, I think retrograde will be suitable for you.
Yes.
سامع كويس؟
لا مش سامعك خالص.
Yes, okay. Next, so.
بس خلاص.
What's your next step?
Again, we will go by a wire and microcaster in the right coronary artery till we reach the collateral, and I will. Let's. Already we have this microcaster.
RAO, please. This is a run through floppy wire. It's we use this wire sometimes for crossing the collateral, but we use this wire now for just advancement of the microcatheter. So we use this. So as you said, this is a very simple collateral to cross, even with the workhorse wire.
So as a rule of thumb, you have to start by the microcatheter from the contralateral artery.
Yes.
Yes. Okay.
And to advance this microcatheter to the occlusion, you have to bring a workhorse wire first, then you advance the microcatheter.
Okay. This is Turnpike?
Yes, Turnpike LP. We used Turnpike LP 150 centimeter microcatheter. The guiding glass is going out.
Okay.
Of course, we have a big bend in this collateral. It might also not easy as we expected. Okay. الجايدنج glass.
Okay.
طيب.
Dr. Nabil, Dr. Alexander Efran joining us. Everyone is joining in the panel now.
Yeah, okay. So we are trying to advance this microcatheter through this collateral, but we have a bend at the start of this collateral, otherwise it's
حضرتك بتادفانس
little bit challenging bend. I think it.
Yes, actually yes. Have this wire.
Okay.
Okay. If you want to.
Okay, just to try. بس حركة الجايدنج معلش بس ان احنا تو ادفانس الجايدنج قلت لي.
عشان يصير
معلش بس انا مش متحكم فيها. سوري. So this bend is very difficult bend.
نبيل.
ايوه.
انتوا حاطين two 7 French catheters right and left?
No, we went through the right radial and 6 French amplets guiding catheter in the right coronary artery, which is a donor artery, and the right femoral 7 French guiding catheter XP catheter for the left chest.
Okay, so sorry, it's Dr. Avram. I saw the presentation, and one very important point is when you plan to go retro, always go with 7 French for the donor artery, because as you can see, you need a lot of support to advance the microcatheter.
Yeah.
Okay? Not only inside the collaterals, but after in the CTO segment, you will need also some push.
Yeah.
So 7 French is mandatory when you think about a retrograde, okay? In that situation, you have two possibilities.
Caravel.
Yeah. I just let 1 second. Because it's Turnpike LP, it's a good profile. It's not a problem of profile, it's a problem of support. So here what you can do is let your wire in the LED it's perfect.
Yeah.
Remove the Turnpike, go with the extension of guiding catheter, and go back and down with the extension of guiding catheter and go back with the Turnpike, and it will cross. Second possibility is to use an anchoring balloon in some marginal branch or distal PDA branch, and then you will increase also your support.
Okay. So we have a guideliner here. Do we have a guideliner here? Okay. We can use a guideliner. Is this L guiding?
You will see. I think it will cross like this.
It will help. It will help.
Yes.
For the guideliner, I will try first the Turnpike LP. I need the trapping balloon, please.
Okay.
Trap it. Yes. Okay.
بالونة صغيرة بتراب الواير بدل ما نجيب بالونات و2.5 معرفش ايه، هي اسمها تراب بالون ديزاين. بتزنق الواير بيترفع صغير فتقدر تشيل المايكرو كاثر من غير ما يكون.
So we'll exchange this microcaster with another one, which is turnpike.
لا هات بس كده قبل كده طلعها بس يا احمد.
First, and if we fail to cross this collateral with a microcaster, we will do what Dr. Avram said. We will use a guide liner to give us more support.
كمان مش هات الثانيه دي في كارفل ام سي عندك ورا
عشان البروجكشن.
ايوه هي دي الخضراء. ايوه
دخلت.
هو ممكن نحسن الريزولوشن شويه يا طارق لان الايمج عندنا شويه.
احنا عشان وركينج على 7.5 فرنش.
اوكي
خلاص اوكي. فين ورينا الترابنج بعد اذنك فين؟
فوقها في الجايدنج.
لا ذيس از ذا مايكرو كاثيتر. وريني الترابنج. لسه الترابنج ما جاتش. كمان حسنا حضرتك كمان
لا هي دي.
لا يا بيه لسه ما جاتش. كمان ما تقلقش دي ترابت كده حضرتك بتقف عند
هي بص متنيه من هنا.
ما هي اوصل الحته دي بس حضرتك.
خلاص
تمام خلاص.
بس حاول على اللصق.
اوكي. ثانيه اتفضل.
We'll remove the microcaster.
اوكي حضرتك بس نفتح تحت.
So explain the manipulation you're doing يا طارق.
This is a trapping balloon. This is a dedicated balloon for trapping. You can use any balloon. In 6 French you use a 2 millimeter balloon. In 7 French 2.5. 8 French 3 millimeter balloon. Inflate this balloon at 16 atmospheric pressure. So you are trapping the wire. So you can remove your microcatheter safely and introduce the other one safely. دي الكرابل.
This is a Caravel microcaster. Caravel microcaster is a tapered microcaster, very low profile, that may help us to cross this collateral.
بس هنحتاج الجايدنج يعني بس بعد ما ندخل المايكرو.
دي بيرل 1.
اوكي
حط البالونه.
اتفضل.
شيل البالونه. اوكي
شلتها حضرتك اتفضل.
You change the microcaster to caravel.
يس زقها بيه جوه.
استنى ممكن نطلع.
طب اتفضل يا
بيه. ماسك الواير؟
ماسكه يا بيه اتفضل.
يا طارق.
يس يا بيه.
احنا عندنا مشكله في الريزولوشن اوف ذا ايمج شويه.
ماشي هات لي واير تاني. هات لي صيون. ماشي يا بيه.
عشان احنا الفريم ريت 7.5
يعني بس عشان احنا شغالين على 7.5 فريمز. مش عايزين نعلي الفريم عشان راديشن بس.
بس مش
اكتر
عايزين
يعني
نشوف.
حاضر يا بيه.
الايمج هنا
انت جايب هنا
ساين واير هنا اهو. ساين
خليك انت واقف هنا عشان
changes the wire الواير الجديد ديت دكتور نبيل.
This is a sine wire, regular sine wire for crossing this collateral because the wire, the old wire is
we can change the collateral
destroyed, the tip is destroyed.
Collateral thing.
So we will see what will happen.
Yes.
The guiding. Okay. The guiding.
Okay.
Okay.
معلش احنا ممكن ناخد الترابنج بالون دي بره لو سمحت. If you are advancing the microcatheter, better to get out the trapping balloon because you are working in a 6 French, and this 6 French is of course can't accommodate both. Yeah, not rotating in this. Okay.
Caravel fast more easily.
I think it progressed. Yeah.
Yes.
Yes, this is the beauty of the Caravel. The entry profile is much lower, or the lowest profile of the available microcatheters now, and it can follow tortuosity better than Turnpike LP. I know Turnpike LP is a good profile microcatheter, but in such collateral we don't want a dilator catheter. We want a pushing catheter. I know it might affect the support in the opposite side, but also I don't think that we need a very high support. ماشي. Okay.
Yes, good progress. Yes.
طارق نارين عكاشة معاك يا طارق. انت دلوقتي الواير اللي هو اللي داخل من الريتروجريد، انت قاصد ان انت تنزله في الديستال بتاع ال دي ولا انت عايز تطلعه؟
Yes, to get a good support. I had changed the position, but just only after crossing of the microcatheter.
بعد ما تزق المايكرو كاثيتر. ها؟
As you see, the collateral is a big one, but unexpectedly it has a multiple tortuosities, so it's a difficult microcatheter.
So because
a difficult collateral, sorry.
I'm watching to you. And I know,
yes.
and we can see, because we can see your end, that you are a little bit rotating the caravel to advance.
Yes.
Okay.
This is the new caravel MC.
I do the same but the point is, you can do it here because it's not a CTO. It's only a matter of profile. But if you will need to rotate it inside the CTO segment, it will break the tip of the caravel. So the caravel,
that is correct.
The problem of the caravel, I'm sorry for Azai, but I don't like this microcatheter. Because the point is, maybe it's the best to cross the collateral because of the profile. But when now you have to cross the CTO segment, it will be the worst one. Because if it's calcified, if it's very hard part, it will not cross. Because you need some more to push it. If you drill it, you will break it. So that's why it's not my favorite one, but I like Corsair Pro. I know that the new one is now Corsair XS.
Yes.
It will replace the caravel. It will be the same profile of the caravel, but you can drill it like the Corsair Pro. So that's why they change their mind also, because they know the feedback about a lot of CT operator. And so I have to congratulate you to already cross the collateral, because it will not be easy. It's not because you can see a very good channel that it's easy. But now I hope that the caravel will be able to cross the CTO segment retrogradely also and follow the wire.
Yes.
Okay. Now you are in the lady and
I agree with you.
Yes.
But now we want to direct our wire. I think we have another problem now for wire direction.
So
yes, field direct TR, please, and bring the cranial angulation.
Tariq, is it wise to inject a little bit inside this microcatheter to see the direction that you want to go in? ولا مش هيفرق؟
I don't think so. We know the direction.
We can inject through the right cranial phalanges.
I will make a big bend for this wire or the double bend to make it go for the opposite direction. I hope so.
So XTA or XTR?
XTR.
Okay, good.
Please bring the cranial angulation. Oh, again, the microcatheter is coming back. We are not in the big collateral, as you see. We are in the small one.
مش شايفين كويس خالص طبعا. مش شايفين خالص يا دكتور نبيل.
هات اريو تاني.
ادينا الاريو.
We are in the small one. So we have to change this collateral. Okay. All right. Just this is why the wire is going down, because we are not in the big collateral.
عايز اعمل زوم اكتر على الشاشه. على الشاشه. على السكرين.
I think tip injection will help a little, as Dr. Nandreen suggests. Tip injection will help you to guide the wire in a proper way.
No, here the wire will go definitely to the retrograde because the collateral is a little bit backward. So I will change this collateral to the other one.
So
yes. Again the same one.
So you mean the occlusion is just after this collaterals? Or there is some way to go?
No, the direction of the collateral at the end.
We are within the body of the occlusion.
Ah, you are in the body of the occlusion. Okay.
Yes. So that's why the wire is not going easily.
Yeah, sure.
Sign black, please.
Yeah, but surfing with XTR is not the best. Huh?
I know. Just I will change. Yes.
For surfing, for my side, the best is Sayon Black. And then Sayon, you will see,
Yes,
Sayon was a great job. Huh? Sayon is the first wire we used was with Feeder FC. Then,
Sorry?
no, I explained just the history of the surfing wire. The first one we have when we start the CTO program was Fielder FC. Then Sayon technology came, and they switched for the new generation of Feeder FC, which is Sayon Black. Okay, so Sayon Black has
Yes, I think the same wire, Fielder FC and Sayon Black.
Yeah, but Sayon Black has the Sayon technology inside the wire, so all the core to tip.
Yes.
So that's why it's the next generation. It's one of the best wire to surf. Huh? So in that point, could you show us maybe the collateral you want to take?
Also not the same collateral.
Because you are going on always on the same, so you need a deeper one.
Yes, I think the collateral is coming from the opposite side, not from this side. It has a bend to the opposite side, then it comes towards the septum.
You are navigating the same collateral now.
Yes, same collateral almost.
So what you can do is stay inside this collateral, because I think this is the main one.
Yes.
And just try to advance your caravel again inside the LED and exchange for a Gaia wire.
Maybe, yes.
And then you will have maybe more support on maybe more directive. This is a different. Perfect.
Yes, yes.
So, but the body of the conclusion was not there.
Wire
It's-
crossed already.
Yes.
Yes.
Very good.
So it's finished.
Yes.
ممكن نعمل trapping.
طارق ده اي واير اللي عدى؟
Cyan black.
Cyan black.
سايون بلاك. اوكي.
Now we can use the turnpike LP, but I think the CTO is not that difficult. So yes, just guiding, please.
So now this is a problem with the caravel.
Yes, guiding.
Okay.
No, now the problem is the guiding is outside.
So what you can do here, if the caravel is not going, what is your possibility?
No, caravel is going.
Ah, okay.
I will take again the turnpike LP.
Why? If okay.
For better support, yes. If not going, yes. But I think this one will go easily.
Which microcatheter is this? It's a caravel the same or you change it?
No, caravel.
Caravel, yes.
The same caravel, yes. Here, as Dr. Avran said, we will find a big problem in crossing this CTO.
Yeah. So, can I suggest you something?
Yes.
So, try to just place your Cyan black inside the left
Inside
guiding.
the guiding and do trapping, yes.
Yes, and
I
it
will
will
do
be
that.
easier and everything will go smoothly like this. But so now you are in good position.
Okay. Cranial, please. هحاول بس ادخلها في الجايدنج. يس.
Just to summarize for the audience, هو دلوقتي he crossed بالواير السيون و he's trying to push his
Cyan black,
micro
yes.
catheter معاه.
Not Cyan black.
سيون بلاك. المشكله ان الكارافيل كاثيتر is not helping him much to go through فهو هيعمل
Perfect.
ترابنج للواير عشان يعرف يزق المايكرو
We
كاثيتر
are in the
عليها.
opposite direction. Please, 2.5 balloon. So now we have the wire inside the 7 French guide, the anti-grade.
And then you will inflate the balloon so the balloon blocked the Cyan black. And then you can pull back on the Cyan black to advance the caravel.
Yes.
So this is a good tip and tricks, but when you are using epicardial channel, be careful because you are make a lot of tension inside the collaterals when you are doing this maneuver, okay? So you have to be careful if you are epicardial. Huh?
Just I'll try to do a trapping and I'll do not tension on the microcatheter. I'll try to do also gentle pushing.
You will
trying
cross.
to advance this microcatheter because we don't have a good microcatheter support.
Caravel.
ماشي طب هات الترابنج بالون. You need a trapper. ما هي لازم كده حضرتك عشان ما تعديش من الجايد.
But you know, in retrograde, like this, the wire, the retrograde wire could cross in 20-25% like this, true to true,
Yes.
because the distal cap is always softer than the proximal cap. And there is sometimes microchannel from distal to proximal, but there is nothing from proximal to distal.
برضه for the audience he is pushing the balloon من غير الواير، يعني هو ما بيدككش البالونه على
Yes.
واير، هو بيدخل البالونه separately جنب الواير اللي هو اوريدي دخله من الريتروجريد للانتي جريد وينفخ البالونه بتاعته على التip بتاعه الواير اللي اتحط في الانتي جريد كاثيتر على اساس ان هو يثبت الواير في مكانه so he can push his micro catheter in. At what pressure do you inflate the balloon يا طارق؟
Yes, inflated the balloon. This is a trapet is designed for trapping only. It's a balloon with a unique size for 6 French, 7 French, and you can see this bend at the balloon so as not to cross with the balloon from the tip of the guiding catheter. This bend will prevent you to push the balloon inside the coronary.
It has a certain pressure that you inflate on.
انا في بالي
Sorry.
It has to be inflated at a certain pressure.
Right.
It's okay at 14, 16 is okay, or 12 is okay.
How about the regimen of anticoagulation, Nabil?
We are checking our ECT. Our ECT is 362, and we will check again now.
We are checking.
So here you have to pull on the cyan black.
Yes, I am trying to pull, but I don't want the guiding to come inside this.
The guiding will not.
LAD. Yes.
It's not. You see the problem of the caravel. Huh?
Yes.
You
So
understand.
we'll go back again to the turnpike LPS.
Yeah, but don't lose your position. So maybe it's
Of course.
sometimes it's good to use extension of wire extension, dock extension
Yes.
here, not to lose your position. Huh?
Yes. معلش شوف لي دوك كده في الجيب.
So as you can see, sometimes the easiest part is to cross the collateral. And after it became very difficult.
To explain for the audience, the problem now is he has to push his microcatheter علشان يدخلها في الانتي جريد catheter. He cannot do this because this is a very soft.
No, be careful with
microcatheter.
your
He cannot push it harder. Yeah.
your guiding, left guiding.
Yes, I left. Yes.
So now he will take it out and he will put the other microcatheter اللي هي turnpike لان هي السبورت بتاعها هيبقى اعلى شويه.
Just the guiding دي we need to make it in position. معلش الامبلتس ليفت. اوكي.
هات الكاميرا على الاي سي تي الرقم، عايزك تطلع الرقم.
طبعا as Tariq explained, we have to check the ACT every 20 to 30 minutes. It has to be over 300 to 360 عشان يبقى ضامن انه مش هيحصل له اي كلوتس في الانتي
retrograde we prefer 300. If you can now see the microcatheter,
this is the ACT that you can see.
Tip is a little bit destroyed. If you can appreciate this on monitor, can increase the frame to 15 عشان بس نخليهم يشوفوا.
The tip of the caravel is destroyed.
Yes, it's destroyed already.
But you know why? You know already why?
I know.
Yes, okay.
Maybe you can explain why.
Because caravel is, you can only push it. If you drill it, you destroy it. So that's why it's not my favorite one. I need to drill the microcatheter to rotate, to advance. But here, if you rotate, the tip is...
Tip already is as you can see, tip is dislodged.
The tip is destroyed. We have seen.
Yes, already. So I will change this one with...
This is the tip.
Sorry.
Yeah.
Okay.
A missed part from the microcaster over the retrograde wire near the left guiding, yes? So Nabil, there's a missed part of the microcaster near the left caster, yes?
Yes.
Yes.
Okay. بس معلش نمسك الشيز بعد اذن حضرتك. I will change this microcatheter again. And I will try to take this tip with the new microcatheter.
What is the type of the new microcaster, Nabil?
It's turnpike.
The old one.
What's your plan for the lost part of the microcaster? It will be snared anti-grade?
I'll try to make it inside the guiding.
He will push it He is planning to push it with the other micro catheter to push it
هات
inside because
البالونة
he
الاتنين ونص
already
معانا.
has the wire inside the anti-grade catheter. So he's going
جبت
to push it
الدوك؟
through.
جبت الدوك يا احمد؟
من التمريض وانا موجود كده وصابر صابر 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 نشوف هو ليه بيقع.
مش شايفين قوي. انا بيتهيألي because of this screen هنا اوضح على الكبيره اوضح. والله؟ لا دي اوضح شويه من اللي عندنا. الدوتس البيكسلز دي مش كتيره زي في الكبيره. الكبيره يمكن احسن شويه. دي احسن شويه.
You have still your cyan black inside the left guiding catheter?
Yes.
Yes.
So you have still the trapping balloon inflated or not?
Balloon, yes.
مش موجود.
Yes, yes. The trapping is still inside the guiding catheter and inflated.
Is inflated or not?
Yes.
Okay.
هو قال لي هنا.
So you don't need to rotate. Just push like it was. It is a caravel.
It's not coming unfortunately. فلش كويس لو سمحت. فلشها كويس. هات لي البالونه الاتنين ونص بعد اذنك. So we need a trapping balloon. معلش هات لي بالونه اتنين.
اتنين؟
بالونه اتنين. بسرعه تهدي.
The microcaster is pushing the whole system while we're trying to advance it over the wire. And we will trap the wire in the amplet right guiding caster to help us to push and advance the microcaster.
مش مشكلة هات 12.
You will trap the wire in the left caster.
In the right.
The anti-grade in the right.
Yes.
هدخل بالونه عشان تراب عشان ما يتزقش.
نستنى لما نخلص هنا
لغايه ما نوصل للاخر وبعدين نبقى نفك التراك. يلا يا باشا.
التمريض اللي موجود هناك. طب انتوا الاثنين هنا.
Tara, explain why did you have to take another trapper?
علشان اما بنخش بالمايكرو كاثيتر بنادفانس المايكرو كاثيتر من انتي جريد جايد الواير بيخش معانا فانا هتراب الواير من هنا مش من الناحيه الثانيه. trapping the wire from the opposite side is very weak and the wire will go. يلا يا باشا. So you have to trap it from the same guiding better. يلا trap. 16 18 بس. ما اقول لك فضي.
Stable.
So you are pushing it وهي inflate.
Yes. فضي. خدي.
الجايدنج ليفت.
This is a big problem. Again. Okay. So I have to rotate now.
الواير عمل
خلاص already. ماشي مش مهم خلاص سيبها حضرتك سيبها. شوف لي الدوك كده لو سمحت. الدوك الاكستنشن فين؟
مش موجود لا هنا ولا هنا دلوقتي.
Nabil, maybe you can change the angulation a little bit because we cannot see the distal part of the right coronary or where the collateral goes. So actually we can't see much of what you are doing.
بدر هات لنا شويه كريم عشان نشوف الدستة بتاع الكورونا.
هات لي الجاكيت
ثانية واحدة.
خلينا على الصغير.
ما عندكش اكستنشن واير؟ ايه؟
اديني فلاش تاني.
So what is the situation now?
طارق هجيب مايكرو كاستر تاني يا فندم. Do you think that we can use a guideliner in this condition?
Yeah, to do what? Antegradely or retrogradely?
The microcaster over the way.
Antegradely, you mean?
No.
We can use this to trap. Yes, you can use this guideliner to trap the balloon more deeply, so we can get the wire.
Oh, but your wire is still inside the left system, no? Inside the left guiding catheter.
Yes.
So it's okay.
Yeah.
It's only a problem of crossing with the microcatheter.
Yes.
Now we are facing a problem in recrossing again with the turnpike.
Yes, because it pushes the whole system back, the left system, when we are trying to advance the microcaster.
In spite of trapping?
Over the wire, it is, it pushes the whole, when we reach the right coronary, it pushes the whole system back in the left system.
هات الفاين كروس اللي عنده. فاين كروس.
طارق دلوقتي you have already
think
created a path with the old caravel اللي هي which was broken. بس هي الفكرة إن الكارفل البروفايل بتاعها is very small, so maybe you can push a new caravel without rotating because you wouldn't have to rotate as long as you have created this path بالمايكروكاثيتر الأولانية.
I will try the fine cross because the inner diameter or inner lumen of the fine cross is better. If we couldn't cross by the fine cross, I will bring another caravel. Yes.
Yeah, but you have to test with the fine cross. It's perfect. But if the fine cross won't cross, it means you have some obstacle inside your wire. I think some part of the caravel, and that's why the microcatheter is unable to advance. Okay, so in that situation, the only way is to remove your retrograde wire and to recross.
I know.
Because
but I don't want to remove the retrograde wire because I don't want to get rid of this part.
Okay, so what you can do also, listen to me, you can do a tip-in. It means use your fine cross antegradely.
Yes.
And place your cyan black inside the fine cross and go with the fine cross antegradly, and it will push the tip of the caravel inside the septal.
Yes, this is a good thing, but also you will face a problem of getting rid of this part. So you will make it between both sides.
You can leave it inside the septal.
Is pointing that he might leave the tip which was broken. He wants to put it in this micro or the small septal in the collateral way. Tariq doesn't want to do so. He wants to get rid of it. He wants to put it in the antegrade catheter and take it outside the patient.
Sorry?
Tariq, we have 10 minutes. So maybe just work بالراحة, take as long as time you want. Just explain the steps you are planning to do, and we still have 10 minutes together.
We are going to take this tip of the microcatheter by the new one inside the antegrade guide. We have to trap this. هات لي تاني البالون. Last thing I will do is
maybe things was going to be a little bit easier if we had an extension of the wire. Or what do you think?
Yes, I think so. معلش عايز بس اشوف الجايدنج شويه كده. هات لي اللي اهو. انفخ. هات لي المايكرو كاثيتر. انفخ.
You are doing retrograde
yes.
trapping now?
Trapping, yes, from both guides.
Avren, do you think that tipping technique in this condition will help, that we can introduce a microcaster over the antegrade wire?
Yes.
Antegrade guiding?
Yes, sure. It's one of the solution, but first of all, the best one is what you are doing. It means try to go with the fine cross and see if with the fine cross you can push the tip of the caravel inside the antegrade guiding.
Yeah.
But if the fine cross is not crossing, it means that there is something wrong along the wire.
The wire cord.
Yes.
Yes, yes. Because
So don't destroy the fine cross and use it integrately after.
Yeah.
So now we are inside the septal because we can see very clearly where you are with the tip of the fine cross.
No, it's still in the right coronary.
But but here he is advancing. Okay.
Advancing, but the wire also is making a loop.
Ah.
On the aorta,
yes.
Where is the loop? So be careful, your two guiding are very deep engaged.
Yes, I know.
Yes.
Okay.
ماشي وبعدين انت هتعقم ادخل بالمايكروكاستر. منير هيتعقم مع صابر. مش مشكلة منير وانت تساعده.
So what is the problem? Because I don't understand. What is the problem?
Every time we want to advance the microcaster over the retrograde wire,
Yes.
it pushes the left system back.
Okay, so it means that there is some obstacle inside the wire.
In the wire itself, yes.
So I think the only way is to retrieve the wire.
Extension is the only thing.
But okay, because the wire is too short.
Yes.
Okay,
Yes.
okay, okay, I understand. Okay, yes, yes, use an extension.
Dock.
So then you push the fine cross, you have not the distal part of the wire outside the fine cross. That's why when you push it, it's loop inside the aorta.
The aorta, yes.
Okay,
it,
okay.
It doesn't come back through the microcaster. It push everything, and even push the left guiding caster back.
Okay.
You think that the shaft of the wire itself might be destroyed? So
Maybe also, of course,
Yes,
because
so
of
yeah.
multiple manipulations, yes.
Yes. Okay, we still have 3 minutes at least.
Yes.
But we will come back after, or not?
So we can leave you to work at ease. So and
برضه دلوقتي to explain for the audience what he is doing, he is searching for an extension wire to make his wire long so as when he pushes the microcatheter it can go all the way without ان الطرف مش عارف يخرج الطرف بتاع الواير لان الواير is very short. ففي حاجه اسمها extension wire, he docks the old wire which is already in بواير تاني عشان يطوله فيقدر يزق عليه المايكروكاثيتر من بره.
Guideliner.
Okay, so what you can do also, if you have no extension, because I think you have no extension of wire. You are looking for it, and so what you can do is place another wire inside the right coronary and do a trapping, but down inside the right coronary. Okay.
But I'll do this with the guide extension. I'll do trapping inside the guide extension down.
Okay.
That's better to do trapping inside the right coronary.
No, but you will
With
not
the guide
destroy the right
extension.
coronary with the trapping. Don't worry.
Yes. Okay, هناخد الاثنين بس. So we are advancing a guideliner so as to trap this. Yes. البالونة.
نبيل.
اطرح.
احنا we have to leave you now and then do your job as in a more quiet atmosphere. And after you finish, you just tell us what you have done.
Okay.
Because the satellite
we'll
time
call you back,
is
Dr. Ahmed.
almost up. So we have
جديدة. بالونة 2 جديدة.
listen
we'll
to
call you
Dr.
back and
Alexander
after
now
we
for last comment before we go. Any advice before we go?
No.
Okay.
It's okay. Do your best, but if I have to bet on something, I think at the end he will remove the wire and re-go again with the wire because it was easy to cross.
Did you hear Nabil?
I'm hearing, yes.
He's recommending, Dr. Alexander is recommending to withdraw all the wires and you
Start
go again
fresh.
from the contralateral side. That's it?
And this if we fail to advance the microcaster over the retrograde wire. We'll just...
Sure. Me too. But if the microcatheter will not advancing, this is the only solution. And maybe when you remove the retrograde wire, you will be with the tip because the tip is like prisoner inside the wire. So if you remove the wire, you remove the tip also.
This is advancing the guide extension inside the RCA turret, صح? Now we see
So
how
the guideliner, yes?
Yes.
Yes. We will trap the wire inside this guideliner deep.
Tariq, you have a minute. Just explain to us ايه الخطة بتاعتك what we are going to do because we are going to go right now. We will be offline. So you have 1 minute just to tell us what are your expectation and what you are planning to do. In short.
I am planning to advance another microcatheter And
Nabil.
then after advancing this
Tariq,
microcatheter, we'll take
listen
the
to
tube
me,
over the wire.
Tariq, listen to me.
Okay. Yes.
Please finish your job, and this please record what you are going to do, and then this will
Okay.
be displayed later on this night. Because we have our time is already up, so we have to go. And good luck.
Okay. Okay. Thank you so much. Thank you.
بياكل بس هو بياكل.
الراجل بص بياكل.
طارق رشيد موجود طيب؟
طارق
لو ياسر صادق بص اسمعني لا اسمعني ياسر صادق انا بكلمه لو ما جاش خلي الراجل بس بيخلص لقمته ويطلع هو يتكلم اول واحد خالص. ما انا الراجل قاعد يدفع هقول له يقوم الراجل يتكلم.
ايوه طبعا.
شد الطبق.
خلي ياكل جوه.
هو بياكل طيب.
يلا اديله دقيقتين طب.
انا فاكر هو واخد تالت واحد.
اديله دقيقتين طب
Alexander, we are sorry to interrupt your meal, but are you ready? Because Tariq Rashid is stuck in the live transmission and Shams. Are you ready? And then we can give you 1 hour extra to start. So Mona will take care of the meal, and if you are ready, otherwise the audience will leave. معلش هيجي بعديه بقى. هو البرايورتي. So it's my pleasure on behalf of my colleagues and friends, Professor Nireen Aukash and Professor Muhammad Fauzi. It's my pleasure to introduce our dear friend, Professor Alexander Avram. He's a very well-known figure and expert in CTO intervention. He will. I have crossed the CTO retrogradely. What is next? Yeah. Why? Okay, Dr. Avram, please start.
Yeah, no problem.
It's not ready. Not ready. أنا خبير في المطبات لازم أخلص أنا عارف.
Maybe till they start, maybe you can.
Yes, no problem. Don't worry. So because I know the
yes,
because it was retrograde step by step first.
Yes, please.
Okay, so
we can start
and
the
my
discussion retrograde.
and my lecture is on after crossing craters.
Yes.
So what we can do is I can explain you how to do a retrograde step by step. It's better like this than going through some difficult parts. So we don't need any slide. You have RCA occlusion. Everybody can see, imagine RCA occlusion, good septal collaterals, okay? So my only way to cross is to go retrograde. Why? Because the occlusion is very, very long, and antegradely my wire can't go through to true lumen, it's impossible. Okay, so I need to go retro. So how to start the retrograde? First, you have to be very careful about the angiogram, the angiography, and just to check which septal is the best one to go. If there is no septal, there is maybe epicardial channel, or you can use sometimes when some graft cabbage, post-cabbage patient, you can use a graft to cross the collaterals also. So first of all is to select the septal. So you go with a microcatheter and a workhorse wire and go inside the septal. Everybody understand? Then you advance the microcatheter inside the septal. Then you exchange your workhorse wire and you use a wire to do surfing. Surfing septal is what we have seen during the live case. So the best wire to do surfing septal, as you have seen, is Scion Black. If you have no Scion Black, you can use Scion, or you can use Feeder FC. Okay? And what is surfing septal? Surfing septal is you let the wire finding the way. You are not here to say, oh, I want to go right, left, let the wire go. So you just push the wire and drill it. If you have some resistance, go back inside the microcatheter and find another way. And then you will find a way. Okay? This is surfing septal. Then what you can do is Japanese guys prefer to do tip injection with the microcatheter to see the collaterals and to find the way with a directive wire to do, okay, I want to go right, this branch, and I will go. Okay, but
Just
it's
we will wait, with
yeah, but
these
it's not
slides
my
a little bit
presentation.
till he finishes what he started to tell us. We'll not start right now.
You can go back. Yeah. Okay. So then, okay, it's as you can see, it's easy to cross the collateral. It's not the problem. So when you cross the collaterals, then you have to follow the microcatheter. So sometimes it's difficult, sometimes it's easy. So choose the right microcatheter. As you can see.
From the last case.
Okay. So in that situation, so you cross the collateral and you cross with your macrocatheter. Your macrocatheter is in the distal RCA now, and you have to cross all the CTO segment. So this is my presentation now. What to do when you have crossed the collateral. And so the easy part is done, but now the most difficult part is done. So how my retrograde wire will cross the CTO segment, and I can make the connection with my antegrade. Okay? So you have two options. As we can see, the wire in 20% of cases can cross retrogradely through to true lumen. It was the case with the live case we saw. The cyan black easily cross like there is no CTO. It was very amazing. But I explain you why. Because the distal cap is always softer than the proximal cap. Okay, so the wire can engage and cross everything. Then, if the wire is not crossing, because it's a very hard part also, what to do? This is most of the time, 80% of cases. Okay, so this is, for example, one retrograde. So you see it's very long. The only way is to go retro. So we cross. And now this is a cyan black retrogradely. But the cyan black is not going inside the CTO segment. He is going inside this side branch because he is too soft to penetrate the distal cap. So you just advancing the microcatheter and exchange this soft wire for a stiffer one. So what kind of wire we can use here? What do you think? We can use Gaia wires. We can use Conquest Pro 12 wire. Sorry. But I think the best wire now is a Gaia wire to start. Okay, so Gaia first, Gaia second, Gaia third, as you want. Okay? So, this is the second option. You don't know the anatomy. It's a very calcified occlusion. What to do? We need to be with our retrograde and antegrade wire parallel. Okay, so we need to advance the antegrade wire and we need to advance the retrograde wire inside the CTO segment. So, we can go with retrograde wire escalation. As I told you, it means go with Gaia second, Gaia third, and try to cross. But the best way is to go with knuckle. I explain you why. You see, it's a very, very long occlusion. I just push my retrograde knuckle, and then the retrograde is crossing very easily in subintimal space. I will not be in the true lumen with my knuckle, but I don't care. Okay? The point is I want to cross my retrograde wire and be parallel to my antegrade wire. So this is a retrograde knuckle. And this is, for example, a retrograde wire escalation. So it was the case of we saw. And this is now a Gaia wire. And you see the retrograde Gaia following the antegrade as a marker. And now we are in the very good position to do the reverse cart because our antegrade and retrograde wire are very close. Okay? And you don't care if the antegrade is subintimal or true lumen, and you don't care if the retrograde is subintimal or true lumen. You only want to connect the retrograde to the antegrade. So for example, here, my retrograde wire is blocked at this point, but you can see that my proximal cap is very ambiguous. I don't know where to puncture. That's why I start this case retrogradely. And then I advance my retrograde wire as much as possible. And now my proximal cap is not anymore ambiguous because my retrograde wire helped me to know where to go with my antegrade wire. You use your retrograde as a target and puncture with your antegrade wire and try to follow the retrograde wire. Look. So my antegrade wire is coming. You can see I have an anchoring balloon in the side branch. So now I am against the resistance. I just puncturing. It's a Confianza Pro 12, Conquest Pro 12. And you see my antegrade wire now is very close, parallel to my retrograde. So here, my antegrade wire is not crossing in true lumen. I am subintimal, but I'm in very good position to do the reverse cart technique. And I will explain you what is the reverse cart technique. So now we have our two wires very close, and we have to connect them together. So reverse cart technique, this is the most important technique to know for retrograde cases. What is it? I will place in my antegrade wire a balloon in front of my retrograde wire in order to create some dissection. So I inflate a balloon to create dissection, and then when my balloon is inflated, I try with my retrograde wire to go inside to stick my balloon. You understand? And then when I deflate the balloon, I just try with my retrograde wire to take the space that the balloon has made in the subintimal space. So this is the reverse cart technique. Create a dissection antegradely with a balloon, and when you deflate the balloon, you advance the retrograde wire in the space that the balloon have done. This is an example. You can see my balloon, I deflate the balloon, and then look at my retrograde wire, I just drill it a little bit, and you can see is now crossing the CTO segment, and I have a guiding extension. It's a guidon or guide liner, and now I just have to advance my retrograde wire inside the extension of guiding catheter. And I try, so sometimes it's going inside the true lumen, but not inside the extension. But after few attempts, you see my retrograde wire is inside my guiding extension. In my usual work in CTO, in 90% of cases, I am using an antegrade guiding extension to facilitate the reverse cart technique. But now we call it the guide liner reverse cart technique. It's a common, usual now. Everyone uses it because it's easier to do like this. So then, now you have your wire inside the antegrade guiding. So what to do? So sometimes your wire is crossing inside the guiding catheter. You don't need any extension, like this. So you are very lucky. The wire is crossing inside the guiding. So perfect. So we can use the guide liner reverse cart technique. So as we have seen,
Can you go back to the previous picture?
previous one is we did
This one. Because you are pushing the wire while the balloon is inflated.
Yeah, this
Yes?
one. Sorry, because it's not my.
You see, you are circling.
Yes.
You are pushing the wire while the balloon is inflated.
Yeah,
from
but the
anti-grade.
balloon, the retrograde balloon cross, and I was so happy that I continue with.
Okay. But
Okay.
this is not the usual. We don't.
No,
This
no, no,
is
no,
not
no.
the usual. Okay.
But
I thought this is a
you
new
have to
technique.
use all the
It's asking.
opportunity you have.
Of course. It wouldn't stop.
So most of time is this. So reverse card technique with the guide liner. We deflate the balloon. We try to take the place with my retrograde and try to place my retrograde wire inside the extension of guiding catheter. Sometimes when you have some ostial, or it's very difficult to intubate your guiding catheter, your wire is crossing in the aorta. So the only way, because sometimes it's impossible to try to cannulate the antegrade guiding catheter, is to snare the wire. But the important point is not snaring the wire who cross. You have to snare a long wire. So RG-free wire, externalization wire. Here I cross with, I don't know, Gaia. I will not snare the Gaia. So what to do first is to advance the microcatheter inside the aorta, exchange this wire, and place the RG-free wire and snare the RG-free wire. So this is RG-free, and then this is a snare. So up, and then I can pull back all my RG-free. RG-free is a 3 meter and 30 centimeter wire, so there is no problem. If you are snaring a short wire, you understand the problem. Okay. So then, when you have done that, you need to advance your microcatheter inside your antegrade guiding catheter. Not after the snaring, because snaring is okay. But if you have done, for example, this reverse cart, now you just advance your microcatheter inside the guiding catheter to exchange your CTO wire for the externalization wire, RG-free wire. So once more, if you are using a guiding extension, it's easier because that shortens the distance between your guiding catheter and your microcatheter. Then you use externalization wire. So the 5 centimeter of the externalization wire is radio opaque, so you can follow it, crossing all the way. And after that, you have 2 important points to do before going with an antegrade balloon. Remember that you have your microcatheter inside the antegrade guiding catheter. So you have to pull back the microcatheter. So before pulling back the microcatheter, if you pull it back like this, all the EBU will go inside the left main. So extubate the donor artery. So extubate the EBU, then pull back the corsair or your microcatheter, and then you can make some predilatation on your RG-free wire and work like this. If you have done some knuckle or subintimal tracking, no injection antegradely. Use the retrograde injection to place the stent in the right position, no antegrade. Because if you have subintimal, if you do an antegrade injection, you can increase the dissection of all the artery. Okay, so no injection, antegrade. So deliver the stent with retrograde visualization. You can see, I can see clearly where I can place my stent with my retrograde visualization. So then you place your stent, everything is good. You have to remove all your retrograde stuff. So remove RG-free And what I suggest to you is to remove the RG3 until you see the 5 centimeter radio opaque part, and you let him in place in your right coronary. Then you remove fixed point and you remove your corsair. You control the septal. If the septal is perfect, no perforation, you can remove RG3. If there is something on the septal, you have already your wire inside. That's why you have to let it back, so you can go back with your microcatheter and deliver a coil if needed. Sorry. Okay, so you see the radio opaque part of my RG3. Then we remove the corsair. We control the retrograde, and we can enjoy our very big, huge RCA, and you can see the collaterals. Always control the retrograde system, it's very important. Okay, so thank you so much. And as you can see, the retrograde is not difficult, but you need to have the good devices. So if you have no long microcatheter, you can't do retrograde. You need 150 centimeter microcatheter. Then you need wires for retrograde. So Scion Black, externalization wires. Okay? And then you have each step I show you could be a difficult step. Sometimes the difficult part is to cross the collateral. Sometimes the difficult part is to do the reverse cart. Sometimes the difficult part is to try to succeed to place our retrograde inside the antegrade guiding catheter. So it depends the patient, it depends everything. So that's why you need experience to do and to know how to deal with each complication you can have.
So does it depend on the state of the collaterals when you select the wire which you are using for the retrograde?
Okay, so for septal connection, my first wire is always Scion Black because I'm doing a lot of surfing septal. If my surfing septal is not working, I will do a tip injection in my septal. If the tip injection shows me that there isn't connection, I will move for another septal. Okay? For epicardial channel, my first wire is Scion. And then if Scion is not working, I use SUO3. SUO3 is a new wire from Asahi, 0.3 gram, very fragile, but very expensive. That's why it's not my first wire, because in France, it's 3 times the cost of other wire. Okay, so that's why I use Scion. Why not Scion Black? Because with Scion Black, it's a very polymeric wire, and in some epicardial channel, it could make some perforation. Okay, so I prefer Scion for epicardial channel.
And for the to complete your pathway with the retrograde wire, and you are now making the antegrade approach again.
Yes.
And you intend to make a dissection if it is not possible to pass through the cap. And so is it possible that the retrograde wire would also would not need antegrade, and you can just use it as like a connection with the from the cap? I mean, what is the level that you can stop with the retrograde, and then you start antegrade and you make them parallel dancing wires and you complete the procedure?
Yes, I understand. In fact, always start antegradely. Okay, if you know where to puncture, okay, always start antegradely, because sometimes because it's a long occlusion, but sometimes feeder XT can cross everything. Okay, you have good surprise. So always start antegradely when you know where to puncture, okay? And then if your wire is subintimal, then you go retro, okay? So then to try to connect antegrade and retrograde, the best is the reverse card technique, okay? So I show you, inflate a balloon, so you need to size a good balloon, because if it's a 3.5 diameter artery, don't use a 1.5 balloon. You need to use a 2.5 balloon to create some dissection inside, okay? Sometimes, so most of times the retrograde cross like this. Sometimes with this, the antegrade finally follows the retrograde pathway and cross. But most of time, this is the retrograde who cross the occlusion.
And for the ostial total occlusion.
Yes. Ostial total occlusion, okay, you have to go through all the pathway, and the difficulty is to exit in the aorta and not in the wall of the aorta, okay? So sometimes you have to use very stiff wire, like Conquest Pro 12, because the ostium is very hard, it's a blunt stump, you need a stiff wire. And sometimes you need polymeric wire like Pilot 200 because it can slide into and find some way. But the point is how to know if my wire is in the aorta or is in the wall of the aorta. This is yes. So you need to see where your wire is going. So just go back, go back. If the wire is always going in the same way, you are in the wall. If you are in the aorta, the wire will go in, stamina, and stamina. Okay? Another point is use the guiding catheter. Let the wire inside the aorta. Use the guiding catheter and try with the guiding catheter to touch the wire. If you are moving the wire with your guiding catheter, it means you are in the aorta, not in the wall. Okay?
You always go antegrade. If you have a CT scan before and told you that you have a heavy calcification from the start and the long segment of calcium, I think you have to go retrograde to
yes.
make it easier.
Yeah,
yes.
but no, because the point is, okay, you will go retro. The final strategy will the retrograde, but after you need also to puncture antegradely, okay? Because the connection needs to be inside the CTO segment, not in the healthy part of the artery. So it means you will lose time with all your retrograde stuff. Try to puncturing antegradely. So if you know where to puncture, always start antegrade. Then you will lose no time for the retrograde, okay? If you don't know where to puncture because it's a very ambiguous proximal cap, then you have to start retrogradely and use the retrograde as a marker for the antegrade puncture.
Like the one you showed.
Yes. If you have a side branch like RV branch and you can land with a wire and do IVAS guided puncture antegrade.
Absolutely.
Yes.
It's a very good situation. But who is in this room has IVUS in his cath lab? Show me. How many guys? So, okay, so 3. You are 3. Maybe, I don't know how many we are. We are 50 people. Only 3 people has IVUS in the cath lab. So this is the first answer. Second answer, who is able to be sure that what is see in the IVUS is the occluded proximal cap? Okay, so you have to practice a lot IVUS to understand, okay? But I totally agree with you. In that situation, IVUS is very good to puncture when you don't know where is the proximal cap.
So
when you have an ostial total occlusion and calcific, you will start mostly retrograde.
Yes, only if you are able to cannulate your guiding catheter on the ostial part, you can start antegradely, because most of time the ostial are very short. You will see most of time when you have an ostial CTO, the retrograde, you will see the flow, the collateral will go very, very high.
Yes,
and I have a question about the feeding casters, antegrade and side holes. Do you prefer for ostial lesions to do side holes?
No, you don't need for ostial lesion. Okay, but for me, I do side hole when I use 7 French in the RCA. Okay? Not in the left main, because left main, you are able to accept 7 French. Okay? Only if he is stenosis, he can't. But 7 French in left main, there is no problem. But sometimes in RCA, 7 French is quite big. If you use Emplatz left, you can make some hydraulic dissection with. So that's why I prefer side hole in that situation. But for ostial, you don't need because you are not intubated.
So when do you knuckle your retrograde wire? What's the situations that you knuckle the retrograde wire?
Yes. So to knuckle the retrograde wire, you need first to be inside the CTO segment. Okay? So sometimes you need to puncture. So my best wire is Gaia. I use Gaia first. So I use it to puncture. And then when I see that my Gaia is not moving anywhere, is stuck, I will push it, it will knuckle and go just in front of the proximal cap. Then go with my antegrade wire and make the reverse cut.
So the aim of knuckling is to increase the space?
No.
Or?
The aim of knuckling is first to be faster, because Japanese guy will never a knuckle. But where I spend 10 seconds to cross 5 centimeters of occlusion, he will spend 5 hours. Okay? So this is the first point. Second point is knuckling. When you are knuckling, you are sure that you stay in the vessel architecture.
Yes.
With a stiff wire, you are not sure. Because when it's very hard, sometimes your wire, you use Gaia or Confianza, you don't know where it's going. Okay? The knuckle stay always in the architecture, so it's safer also. Okay?
So last question is the retrograde and its very proximal occlusion, and many times there is also extensive calcification. So maybe you reach it up until the proximal third, but there is calcification, and then do you think that having CT from the previously, or if you can use, if IVUS can be of any help in these situations?
Okay. For me, I don't care, because I will go subintimal. So when I am subintimal, I don't care about the calcification in my CTO segment. I care about calcification if my wire is true lumen. Because if my wire is true lumen and there is a lot of calcification, my microcatheter will not follow because he is stuck inside the calcification. But if you are subintimal, you don't care because the calcification are inside. But CT scan could be good if you really want to know the anatomy of the vessel, because sometimes we think that the vessel is straight, but there is some curvy part. So CT scan could be good in that situation.
Okay, many thanks, Dr. Efron. Anybody from the audience want to ask about CTO procedures for Dr. Efron, which is the most expert worldwide now?
No, it means that everyone now understands and will go back to his cath lab and doing a retrograde, okay?
I think you had a very good chance to make it interactive session, and we had a good experience from you in the retrograde and also the antegrade and some tips and tricks. So I think it was very useful. It's like a state-of-the-art lecture. It is not a session because the other two speakers are stuck in the cath lab, but let us say that it was a state-of-the-art lecture on retrograde CTO challenges. Thank you very much, Alexander, and I think we will conclude the session.
Okay.